kicked off the board a bit early, simply because of traffic issues around here at Macclesfield. Our hope and expectation as members of the public will join us at some point in time, and we can have the public talk session at the end of the board meeting. So we brought our agenda a bit forward, and we've just covered welcome, introductions, the decision log, actions, and the resident story. So we're now on to the report of the chair, which I will give. You can see the paper in front of you. I'm not going to go through the details. I just want to pull out one thing, and that's the establishment of the ordinary member, i.e. the partner member of this board, an additional one, should I say, not the establishment. So you can see some of the rationale, and essentially, this is part of our journey, I would argue, about ensuring that our colleagues in the voluntary and charitable and faith sector feel that parity that we talk about, feel as though they're full members of the ICB. Having a partner director on the board who represents that group of partners that we have across Cheshire and Merseyside, I think is a really important thing. So I am asking for the board's support for that. Just to say something about process. For each of our partner directors, or the majority of them, we followed a process which is essentially to say to the sector who's interested. We use various different mechanisms to do that. If there are more than one, we will have a selection panel. I'll chair that selection panel, bring other people up from the board into that selection panel, and we'll make a decision about the partner director, subject to you agreeing to the establishment of that partner director. And people happy with that? Yes? Okay, we'll take that forward. I just wanted to say a few other words about another thing that's not in the paper. And it was kicked off by a conversation with Steve, Claire and myself about a paper that was written by the Fabian Society around social care. Steve sent that to us in the summer, and we eventually got together and had a discussion around it. And the reason why the paper is notable, I think, because it sets out both the challenges of social care, but also some thoughts about how partnerships and integrated working could make a difference to the current challenges in social care. And I think a lot of us around the table are fully aware of what those challenges are, both in terms of to those residents and those service users, but also to the whole system. And the thought is, we can either sit and wait for something to happen, or we start to explore what could we do in partnership with local authorities, voluntary and faith sector, about how we could start to challenge, mitigate some of the challenges that do exist today in social care. That paper, and we'll circulate it at the end after this meeting. It's a really good read. It's relatively short, but it sets out some principles and some actions that's aimed at a national level, but could equally apply, I think, to a regional or locality level. And it's those principles and recommendations I thought it was worthwhile exploring. So the question then becomes, how do we do that? This is just for information. I've suggested that we get together with some political leaders and other leaders in the health and care system in Cheshire, because we need a footprint where we can just have a conflab amongst people, and discuss the paper with them and explore opportunities that they see in those principles and recommendations and other things. For us to, over time, this is not going to happen, in the next few months. Sorry, we won't come up with recommendations in the next few months, but perhaps across 2024, we will identify things that this board may want to look at, may want to explore further. So it's a chat. It's trying to get people's understanding and interest in trying to ameliorate or even solve some of those challenges that social care is providing to us. So that's just really for noting. So, had your support for the establishment of the new partner director. Are there any other questions, comments on my report? Steve?
Well, obviously welcome the focus on social care. And thanks for doing that, Raj. Well, obviously social care continues to have a number of challenges in terms of its function, purpose and its financing, and the demands on social care, adults and children are indeed relentless and are causing some councils even to declare bankruptcy notices. One yesterday was Nottingham City Council. So welcome that, not just about the issue around the funding, which is indeed a national issue, it's the wider issue about how we integrate social care into the work of this board. So welcome that. The paper's called the National Care Service. I went a bit apoplectic when I saw that. I wondered what that meant. Does it mean the nationalisation of the care service by the NHS? I'm pleased to tell you it doesn't mean that at all. It's an attempt, I think, to get a better set of standards between all the different local authorities to provide social care, so we have a more appropriate model for integration of those services.
Thanks, Steve. Are we happy to move on? Sorry, Graham and then Claire. Claire?
It wasn't about that item actually, Raj. It was more about the terms of reference of the HCP. We need to formally...
Okay. Claire, do you want to go first, terms of reference?
Yes, so members will know we work as part of the HCP, the Healthcare Partnership, and we spent a number of months trying to get the terms of reference signed off. So I think we are the last member partner to receive these. So just sort of comments and welcome the board's approval of these terms of reference, which we can then take into the next meeting of the board. All the other our local authority member partners have signed these off over the last couple of months, so it's just important to note that today, please.
Thanks, Claire. Yeah, important to note. People happy to approve those terms of reference? Graham, did you want a different issue?
Thank you.
Okay, thank you.
Chair, within the papers you've published the material that was submitted to the HCP Health and Housing Summit. And I know there's a lot of papers there, but I just want to commend those to the board, particularly anybody who didn't have the opportunity to experience the debate that day, and also the recommendation to create a health and housing forum moving forward. Sadly, I wasn't at the Health and Housing Summit. I think I was on annual leave that week. But one of the things that I just wanted to reflect upon is the willingness of housing partners to work with us, and the evidence that they are already changing the way they prioritise their work when we are able to share good information with them. So you've heard at this board before issues associated with people living in cold homes, the problem that has with respiratory disease. Well, the Health and Housing Summit will create a structured way for us to share that information, to do that at every level with every housing association. But actually we do that from a feeling of positivity. They are absolutely welcoming this, and there's already evidence that they will change their priorities to support those people with health needs.
Thanks, Graham. Well said. People happy to move on? Good. Okay. Graham, shall we go to the Chief Exec's report?
Thank you. As people know, we put a range of issues in the Chief Executive's report. I won't introduce and discuss them all, but myself and colleagues are happy to take questions on any items within there. I do just want to highlight a few issues for you. Firstly, to ask the board to adopt the terms of reference of our internal task and finish group to deal with matters associated with the Thirlwell inquiry. To also tell you that we have already received something called Rule 9 letters, requiring us to submit both a corporate statement but to answer around 50 questions, many of which go back to 2015-16, some of which are more contemporaneous about what are the systems and governance in place today. Now, as you know, we are the legal successor body to the former CCGs, and you will also know that we employ a number of people who were employees of the relevant CCG at the time. So really important that not only do we manage this really well, but that we support any of our staff who were working in the system at that time to be able to give evidence and to feel safe in giving that evidence. The other thing, and I believe we may have noted it last time, but again, the appointment of a solicitor to support the organisation in doing that. Now, this might be the name of a legal firm that you have not heard of before, but one of the quite important things is, as the Countess of Chester, NHS England, Liverpool Women's Hospital and others will also be respondent to the Thirlwell inquiry, we chose to go with a solicitor who is an expert healthcare solicitor, but from slightly off our patch, so that we weren't in conflict with any of our immediate neighbouring bodies in that regard. The other thing that is just worthy of note is you will see that we've asked Chris Samosa to chair that task and finish group to manage this, because as you all will know, prior to coming here, I was an employee of NHS England for 10 years, and I might be in their chain of assurance for the evidence that they are required to give. I don't think I will be, but it is just possible. So to make sure that at any point in time we have to put a division, a kind of an information wall in place, Chris will chair that group. Moving on, of note, the provider selection regime has now gone through its passage of legislation and comes into force on the 1st of January. This was always a promised piece of legislation that was supposed to go hand in hand with the creation of ICBs that would move us away from the statutory requirements to competitively tender some services and to put us in a place where we could make decisions based on the interest of collaboration and integration to not use competitive tendering. It's only just been published as a piece of legislation. It comes into force from January, so we will be working through very carefully what we can and cannot do as a result of the new provider selection regime. But I think this is only good and helpful, and is part of moving us to a place where we can make collaborative decisions. Forgive me, I just need a drink. Next thing I wanted to highlight is there's a paragraph in there about addressing financial challenges. And I suppose at one level I'm addressing this to you, Steve Broomhead, who frequently challenges us to say the problem with the NHS is you don't seem to have to balance your books at local level, where us local authorities have to balance our books in every local authority in every place. Well, the NHS does have to balance its books. It has to balance its books, and it does that once nationally. And what that creates as a situation is the NHS does not hold contingency reserves at every level of the NHS. It holds them once, and it holds them once nationally. It also works under a mandate to the government, and because there are some things that are out of the NHS's control, particularly industrial action and the pay disputes, the NHS as a whole went back to government and asked for more money this year. The government's response was perhaps not as positive as the NHS has hoped for, but on the back of those debates, more money has now been put into the NHS at local level. So what we find ourselves with today is we find ourselves with the month 6 finance report in our papers, but Claire will update us later on the additional resources that we have been given to deal with the consequences of industrial action, the resources that we haven't been given that would have dealt with those things fully, and the consequences of that and how we're going to deal with that through to the end of the year. So that is very significant for us and does change the goalpost slightly in terms of what we must achieve this year and where we must land on a hard financial control position by the year end. The other thing that's really important to say this isn't just about the budgets that we directly manage. This is also about the whole financial system for the NHS, where we have to bring that together and support the NHS trusts and get them to land on agreed control totals for the year end. So you're going to hear lots more about that from Claire later throughout the morning. NHS Impact is in there. And if any of you had seen this, the King's Fund and the Health Foundation and the Q Foundation published a joint report this week, authored by Chris Ham, celebrating much of the great improvement work that happens across the whole of the NHS, the continuous improvement, the quality improvement that is being led at every level and at every part of our NHS. And it is something that is worth celebrating. But the creation of NHS Impact is going to be not a way of standardising the process, but a way of standardising the principles of embedding continuous improvement. It will be the opportunity for us to assess both ourselves and all the organisations within Cheshire and Merseyside for the methodology they are using and the consistent approach. So I commend the NHS Impact Establishment to you, and Rowan will be bringing back papers on that, how assured we are about its penetration and use across the whole of the system to future board meetings. To end my report on a couple of positives, I have now worked in the NHS for, and I'll have to work this out, but I would probably say at least 35 years, because I did have a very small stint in local government before I joined the NHS. And in that time, I have only ever come across a very small number of people who have been given the accolade of Queen's Nurse. Yeah? It is something that recognises the absolute pinnacle of the nursing profession. So it is with absolute great pleasure to tell the board that Chris Douglas has been awarded the accolade of Queen's Nurse, and will be going down to London to receive that directly early in December. So, Chris, that, you know, truly is an achievement for you, a recognition of your professionalism and leadership, but actually I also think it is an exemplar to all of the other nurses in the system to be inspired by. So, well done, Chris. And then finally, there is something that happens on an annual basis. The trade journal of the NHS, something called the Health Service Journal, has an annual awards ceremony. It gives awards in about 10 categories. And each year it's an opportunity for people to put forward examples of good practice. And again, it's with great pleasure to note that CMAST, our Acute and Specialist Services Provider Collaborative, were awarded the prize of Collaborative of the Year at this year's HSJ Awards. And it was good to see that a good time was had by all, and one or two of our colleagues went down to London to represent the Cheshire and Merseyside patch and receive that. Now, for me, what I would remind you is when the ICB was formed, we said, and we've been very clear from the outset, that the ICB is about both integration and collaboration. And so as much as it has been about the old strategic commissioning system and the way that we integrate and work with our local government partners, it was as much always going to be about the collaboration that could be achieved by our providers and working in a new way. And so it's always been important to me that the provider collaboratives were here at the start of the ICB, that they're led in the way they are, and I am just so pleased that Anne, you and the team have got the recognition that's rightly deserved. Any questions?
Thank you, Graham. Any questions, comments for Graham? Steve?
Just a brief response to the your point about funding. I mean, obviously I do understand that NHS does balance its books, For the purpose of the ICB, I've always been interested in issues around balances books at a more local level. Every year we start with a deficit budget. We're not allowed to do that in local government. Every year we see top-ups coming from national government. Presumably there will be a top-up for the consultants' reformation of their contract. Millions of pounds may need to be found for a deal struck this week. Local government has issues around local accountability, transparency. In relation to social care, we had a precept of 2% on top of council tax. These are very different issues, and my concern has always been about the transparency and the accountability of resources for trusts and other providers in our system. So I take your point, Graham, but there's two different issues. There's a complete lack of transparency of how the Treasury operates, the Department of Health, in order to balance the NHS books. I'm not always certain that's done in a very efficient and effective manner. At least the books are balanced.
I'm not sure that needs a comment. Steve, back from Graham. Is that okay, Graham? Yep. Yeah. Any other questions? Ruth?
Thank you very much for the comprehensive update, Graham. I noticed you've got statistics about COVID-19 vaccination programme, which is underway at the moment. I had a question about the care homes. It says that 97% of care homes have taken it up, but I don't see the uptake amongst residents, because obviously we've already mentioned social care is a really important partner. So I just wondered if you knew actually what proportion of care home residents have taken it up. We've got the population stats for the general population there. That was my first question. The second one was, I was looking for the flu vaccination campaign and how it was going. It's not in the winter plan, and I can't see it in the performance statistics. So I wondered where we are with flu, because as of yet, the flu hasn't really taken off yet. So there's a real opportunity to make sure we're fully vaccinated for this winter. So I wondered where we were. Thank you.
Okay. So on the COVID-19, we received a very extensive data pack into our exec group. So we'll see if we can just isolate out the care home take-up numbers for you. I have a feeling that Fiona might actually be looking for it as we speak, so I'll keep talking to give her the chance to do that. On the flu campaign, the first data set for that has only been made available to us within the last couple of weeks. And one of the issues, because of the multitude of ways that the flu vaccine can now be delivered and the speed at which it makes its way back to the primary record, there are some issues around data anomalies. But what I can tell you is that Cheshire and Merseyside is slightly ahead of the rest of the Northwest in take up on the first month's worth of available data. But it is certainly something that Anthony can put into the performance pack for later meetings. But the trouble is, by the time we bring it to a later meeting, it is too late. But what you will know is it's information that is out there. It is available to all of us. It is available to us at practice level for practice take-up, but it's also available to us at hospital level for the vaccination of hospital staff. And again, we already know historically where hospitals are now compared with where they were at the same date last year. And again, we disseminate that information out to our hospital leaders so that they can push their teams to up the level of vaccination, because certainly keeping our staff safe and in turn keeping our patients safe is really important.
Thanks, Graham. Any other questions? Just one from me. The comments. The section on NHS impact. It led me to think about this, which is there is ample evidence out there that says the best health and care organisations in the world have a strategic and a very disciplined and serious approach to improvement. I think this is not meant, but the paragraphs in your report sound as though they're a response to a national initiative and us thinking about how we're going to assure ourselves against that national initiative. ideally, I think what we should have as a board is as a discussion, but a belief that this organisation, both in terms of its own people, but also in terms of its system role, can demonstrate a strong, if not fabulous, approach to firstly understanding what improvement is about, developing with our partners a strategy towards continuous improvement being embedded in our organisation and in every organisation across the system. Seeking to understand what our role in the system is vis-a-vis improvement, how we work with organisations like the Collaborative on Improvement, building the capability and capacity of our Cheshire and Merseyside partnership so that it becomes an exemplar around improvement and the application of improvement. That sounds like a big ask, and it is. Some of us have been through this before, and it's not an ask that will be delivered overnight. We're talking about multiple years. But I'm of the strong opinion that if we don't have a really significantly strong approach to improvement, we would have missed many, many opportunities to improve patient care, the efficiency of our organisations, and quite frankly, the passion that many people in health and care have for improvement and being able to tap into that passion, that discretionary effort to support fantastic care across our system. That was a bit of a preach, wasn't it, for me? So I would like aiming at our execs, really. Perhaps Fiona, you might want to give a comment. I'd just like a comment back on that. Is it something our execs are thinking of, or is it really you're doing a tick box exercise saying we'll tick off what's required of us from NHS Impact?
I think Fiona will give you a really positive response, then I'm going to challenge you.
Okay.
Correct. So this is an agenda that I am increasingly excited about. I think it presents a really huge opportunity for us as a system. We have already made some progress. We were thinking about an improvement hub before NHS Impact started. That was Cheshire and Merseyside. We've now got a Cheshire and Mersey Improvement Network, which has met for the first time, and that's got all of our organisations. It is trust and acute and community providers at the moment. However, they are absolutely committed to bringing primary care into this. For me, I think one of our biggest opportunities for embedding continuous improvement is in primary care, because it's so disparate and it will benefit greatly from that collective response. And I think it is about a cultural shift rather than us measuring, and I think that our role is to corral, inspire, coordinate the system in that respect, and yes, as an exec team I would say we are up for that. Positive, yes.
Okay. I agree with everything that Fiona said, and remember that my start point was to say much of this happens already in a bottom-up way through our clinical teams, through our frontline service teams who have that absolute desire to get things better on a day-by-day basis. Every one of our organisations subscribes to something called the Advancing Quality Alliance. We work with the Academic Health Sciences Network, and different organisations do things in different ways. NHS Impact was not an attempt to say everybody must do this the same way, but it was an attempt to say if you look at the world's 5 leading approaches, they all have these common principles. And it's an urge to say to people, if you adopt these 5 common principles, then things will become better in the NHS. And one of the issues that I think the NHS often suffers from, and we might bump into a couple of those issues as we go through the agenda later this morning, is the adapting and the adoption of ideas, or what you might hear sometimes people talk about is the not invented here. So why is it held up as an example of something great that happens over here, and then people say, oh, well, you're not doing very well? Well, it's because people haven't gone through the improvement journey themselves. You can't sometimes just take a good idea from elsewhere and copy and replicate it. After all, we are human systems. But if it feels a bit like there's an element of an assurance exercise to that, I don't think we should apologise for that, because we are not a direct care delivery organisation. We are the organisation that brings the system together, that sometimes has an assurance role, but most of the time should have a partnering role in supporting and developing the way that we do things.
Ooh, this could be interesting, couldn't it? You could have a difference between chair and chief exec. So, I absolutely agree with everything you say, Graham. However, I remain to be convinced that we have taken all those opportunities to empower, facilitate our frontline staff with the appropriate systems, processes and leadership to enable them to do what they want to do with improvement, and to have that strategic approach that the evidence base shows can deliver remarkable results even in the most challenging of times. So I'm going to suggest we don't continue the debate, but I'm going to ask, through Graham, for us to have a paper coming back at the appropriate time on what could be our approach to improvement, for debate and discussion, identifying the role and the priorities that we may engage on, and how could that be done, how could that be resourced.
Okay. Well, we accept that challenge. The paper did indicate we were going to come back in early 2024 and do that. And I think that will be a co-production between our medical directorate and our two provider collaboratives.
Good. Thank you. People happy to move on? Anne?
Thanks, Mark. Just to say that as a provider collaborative, we've really embraced this right from the word go, because improvement has been our kind of second line of our ambition. So we've got like a productivity academy to help people improve productivity, and we've got loads and loads of examples we could give of where, you know, if some trust can do something really well, why can't we all do something really well? And, you know, this is particularly the clinicians I'm referring to now. You know, go around and, like, explain to people in the most constructive possible way about, you know, how they managed to get whatever number of cases are on a list, or whatever number of, you know, x-rays can be done in a session, or what, you know, whatever it is. So we've been really quite focused on that. And then we thought we'd better do something more about quality as well as just getting the performance right. So we've also got a whole work stream led by another most notable nurse, and Julie Tunney, who was honoured at one of our meetings in the past. So she leads on that to make sure the same thing is going on in terms of if there's a qualitative thing we can learn from each other about. So we really have embraced that whole idea of so everyone's good at something, and we need to get everyone levelled up to the best that we've got on our patch and the best we've got outside of our patch to use as an example. So it's the, you know, just to kind of, I suppose, triangulate what's going on, you know, at provider level. We're really on with this now. What you might say is that systematic enough? That's something we can think about in the paper, I suppose. But it's not to say for a minute that we're not really totally focused on how we can improve, you know, both in quantity terms, productivity, but also quality terms, by sharing with each other and helping each other out. So that's the kind of, that's really embedded into CMAS approach, at least.
Thanks, Anna. Listen, I know there's great work going on right across our system. I know I'm pushing against a very, very open door that many people have gone through. But we have got, at least in parts of our system, an absence of and a consistent improvement approach. I think you highlighted primary care. Fiona, primary care has got some great stuff going on, but it doesn't have that systematic approach to improvement. So let's have that paper coming in March. Will that be right? And we can debate and discuss it at further length. Fiona?
I was going to answer Ruth's question, if that's
Oh,
okay.
yes, go
If
on.
you I'll move you on, get you out. I have got uptake figures for our housebound residents are 77%. So our care home residents will be within that, and traditionally have always been higher than that, but I can get you the breakdown for specifically care homes, so it's usually in the 80%. My biggest concern about both the flu and the COVID programmes this time round is the low uptake in healthcare workers and social care workers, and so we are the programme. I chair the programme board, and I am in the process of writing out to all of our organisations to. I know that they are already doing lots on this, but to ask them to just do that little extra push.
Thanks, Fiona. If it's okay, if we could move to the report of the Director of Nursing and Care, Chris.
Thank you, Raj. So the report highlights a number of areas that may have an impact on quality and safety within Cheshire and Merseyside. And you'll see from the report there's a focus around social care, nursing and the workforce challenges that we face. We've already established several work streams to raise the profile of social care and nursing and encouraging student placements and upskilling of staff that currently work within the sector. And I've referenced in there the NHS long-term workforce plan, stating that there's 3 things that as health and care systems moving forward we need to train, retain and reform. And this plan assumes that the balance of care between the NHS and social care will remain broadly the same. So in Table 1 it illustrates the staff numbers and bed availability within NHS secondary care and social care, and you can see the stark contrast in the numbers. If you look at the numbers of registered nurses within healthcare and social care in relation to the number of available beds, and therefore the staff ratio, we need to do everything that we can to develop, educate and reform the workforce to ensure we can deliver the care that's required of high quality and safe within our sector. There are a number of pieces of work that we've established, and I'd just like to mention 2 of them, and that's the Social Care Forum. So we established that over a year ago now. It continues to meet every month, and it provides peer support and a route for staff employed within social care into the ICB to discuss any issues and concerns. Feedback that we receive from there is it's beneficial, it's dedicated time and space, and it helps our providers within social care to come together. We've had feedback from students as well, because we've had an increased number of student placements as part of their commissioned training programme, and they've welcomed it as well. And it's good to see the increase in numbers of student placements within our social care sector. That forum has also been involved in deciding how we spent an allocation of money received from NHS England for continuing professional development, and I've mentioned in previous reports about how that programme for upskilling our social care workforce has been progressing, and we're demonstrating through there we've got co-production and collaboration and support. And then there's the Social Care Nursing Advisory Council, which is a national piece of work that focuses on raising the profile of social care nursing and encouraging ICBs and social care sector to work together. And I'm pleased to inform the board we held our first meeting in this month in November, and we were fortunate to have Deborah Sturdy, who's the Chief Nurse for Adult Social Care for England, join us to kick off our inaugural meeting of the Nursing Advisory Council. So I'd like to move on to the Patient Safety Incident Framework Response. So the board will have been made aware around the implementation of PSURF, and I wanted to inform the board that to date 14 of our trusts have signed off and ready to implement, with the remaining 2 by the end of this year. We've got a robust project plan in place, and our next steps will be to implement a proportional approach to are independent providers, where there are approximately 800 within Cheshire and Merseyside. So clearly it will need to be staged, risk stratified and proportionate also to the contract value. We're still awaiting further guidance for the implementation of PSERF within primary care, and also further work to implement for our maternity providers across the system. Our local maternity and neonatal system have established a task and finish group and are looking at sign off with support from the region of April 24. Those are the areas that I wanted to highlight today in the report, but I'm happy to take any further questions. So thank you, Raj.
Thanks, Chris. Any questions or comments, Chris? Hilary?
Yeah, social care, Chris, well done. You've done so much with so little. And just that table there, I mean, the amount of registered nurses who have to lead a significant amount of healthcare assistants, unregulated staff, is far in excess of the ratio you get in secondary care. Now, I started my career off in a care home, and during COVID, I worked in care homes as well. And the leadership required of registered nurses in that sector is absolutely phenomenal. And they're dealing with risk. They haven't got huge medical teams behind them. They haven't got bleeping machines or access to easy diagnostics. So there's something about their narrative being asset-based in what they can give to the ICB in terms of their clinical skills, not just clinical skills, but leadership. And I think what you're doing is brilliant, but there's something about how do they feel part of the solution and part of the collective skill base. There's something about the narrative of that. And I think secondly, it's great that we're absolutely investing in their training and development with the little money we've got. Are we matching what is actually needed, particularly going into winter, because we need these nurses operating at the top of their licence? So have we got nurse prescribers in there, you know, and people who can do advanced clinical skills? And is that something that we can help local places identify and use, you know, some collective resource to over and above the ambition, over and above the resources that we've been given? Just a thought and food for thought that we can think about.
Thank you, Hilary. I mean, clearly from an advanced practitioner point of view, I don't think we have any nurses with advanced practitioner status within the care home sector. But the focus of the continuing professional development is on their recommendation and suggestion within that sector was around the upskilling of caring for patients, particularly at the end of life. Yeah. And that's part of the training and upskilling that we are working in collaboration with our HEIs, particularly Chester University. And we are taking that training and education out to the providers so that they are not having to come into universities, so that we can actually get to as many people as possible. I think as we strengthen within the social care movement, if you like, for a nursing workforce, we will focus clearly on leadership, and clearly it's something I'd like to look to ensure that we get advanced practice and potential for nurse prescribers within that setting.
And also the volume of healthcare assistance we've got, which is huge in the care sector. What an opportunity to really ramp up our apprenticeship pipeline for registrants in the future.
I'll take that back through to the forum. Thanks, Helen.
Brilliant, brilliant, thanks.
Thanks, Hilary. Erica?
Thank you, Chris. Sorry about this. I want to take us back to something you were talking about last time we were around the table, and that was CHC. And why I'm asking is because we're going to go into finance next, and it's going to be critical, or one of the critical things that we're challenged with. Just a quick update on where we are with CHC. Just I think it's good for everyone to know before we go into finance. Thank you.
Yeah, can do. I can give an update, and then Claire may want to come in as well from a finance point of view. So we're still continuing the review of how we in-house the model and to have a standardised approach, but ensure quality of the packages of care. We're also, from a quality point of view, how we meet the requirements of the packages that are delivered and the reviews. And I think there is further work to do around the workforce, Erica, on that. And you know, I think I mentioned last time around us not achieving the performance standard that was required for reviews. So we are looking to how we can use another party really to support us in how we can improve the reviews of packages of care. And I think, I don't know, Claire, if you wanted to mention, or Claire, the other work that we did in respect of how we can ensure that the packages of care, so particularly around one-to-ones, and that is the review of that package of care that's been delivered, so that it's the most quality effective, but also cost efficient as well.
It is really helpful, and it's a really difficult question, but when do we think we will get some idea of what that needs to look like? So it needs to hit a minimum standard or better in terms of quality. But the standardisation across the whole of the system is actually a really difficult thing to achieve, isn't it?
Yeah, and we would we're proposing to complete the review by the end of this financial year, with the review to commencing in April with the new model moving forward.
Thank you. Ruth?
Thank you. Just a couple of quick points. I was really pleased to see the engagement and support for social care nurses. I think that's really refreshing and encouraging. I wanted to just make a comment that the Health Foundation and the ESRC have funded a 7-year programme for quality improvement in social care, bringing evidence into practice. And it seems to me, linking back to the previous comment about NHS impact, there's a real opportunity. If you've got this level of engagement with social care and there's a nationally funded programme, whether when the paper comes back, we could have NHS and social care improvements in our mindset, because it sounds like you've got really good basis for that relationship to develop. So that was my first comment. The second one was, I was really pleased to see reference to the work on infection prevention and control. Absolutely vital. And I did look at the healthcare acquired infection rates in the performance report, and was a bit concerned about statements such as absence of avoidability. We know these are acquired in healthcare settings. So I was just wondering whether in the review of governance we're also reviewing what people are actually doing about it, because the data looks quite worryingly consistently high. And we could come back to it in the performance report if you prefer.
I can.
Chris, just before you come,
sorry.
let me just add that my comment was about IPC was to have a better understanding of what you think our role in IPC is. If you could add that into your answer. So.
Yeah, I think that was the reason why we've asked for the review to be done of our legal responsibility and our responsibility for infection prevention control as a system. So with I'm sorry, Ruth, I was listening to Raj. Your first point was about the IPC.
I welcome the fact you're looking at the roles
Yeah.
and responsibilities, but it's also what action is being taken.
Yeah, so
because in the performance report, there was a sort of sense that some of this is not avoidable, and
so,
we know it's avoidable harm.
Yeah, we feed through into Quality and Performance Committee every month, so we have place reports from each of our 9 places. And there is feedback through into the place report around infection prevention control and the data and the concerns. So the place reports that are fed through into Quality and Performance Committee has had a focus around C. difficile toxin in particular areas and what we are doing that within place. And then when we get feedback through from the place reports that is impacting across all areas, and it's how we look at that as a system and how we're supporting our NHS providers with that. So there is further work to do, clearly, hence why we've asked for the recommendation to do a review and also review the governance processes of it. But that's how currently we provide assurance on it, and also through the performance data in the report.
Sorry, Ian.
My next theory on Chris, but it's more for make the boards aware as well. So I really welcome the infection control review. Fiona and I have been working following a request from the UK Health Security Agency around some of the challenges on TB, latent TB screening that we have, and some legacy issues around that. We're not on our own there, with our colleagues in other parts of the Northwest looking at that, and it just seems really timely given a lot of challenges more we're seeing in other areas that not around migrant health, asylum seeking services, refugee programmes, as well as poor overcrowding homes, etc. We're seeing more challenges around that. It would make sense if we can try and align some of that work as part of that review, if that's okay.
Yeah, we'll do. Thanks, Ian.
Simon?
It was just to follow on from Chris's example of how the quality system works. So we have within your quality framework local quality groups, as you mentioned, and the focus of the local quality group in Wirral has been around C. difficile particularly, antimicrobial resistance and how we tackle that as a system. So all system partners involved in that, and there are regular reports on progress around those areas to our place-based partnership boards, so all partners are tied into that, and it was the subject of our place-based partnership board quality report a week ago today.
Thanks, Simon. Tony?
Right, thanks, Rose. Just to continue Chris's points about the need to review infection prevention control governance arrangements. So what's prompted us to be able to do that with some confidence is the increasing accuracy of the reporting. We're now not just reporting as aggregate level, we can now break it down and then examine each provider and the impact on place. So that gives you a baseline from which we can change. So I completely support Chris's view there. The reporting is regular, and my experience over the last years, it's increased in its quality and increased the debate at the committee considerably. So looking forward to that step change forward, Chris. Thank you.
Thanks, Tony. So, Chris, you presented this report for noting. It's gone a bit further than that. So Hilby's point about taking the opportunities around nursing in social care, and Ruth's the opportunity around the national funded programme that we could, or we should, I think, is the emphasis linking on. So if we could take that forward. Erica's point about the CHC being really clear about when we're going to get to that standardisation. I think you said at the end of the financial year, implementation in the new financial year, hugely important to us. And then the discussion about infection control. Two things fantastic that you've initiated the governance review. That governance review, I'm assuming, will take into account Ian's point about TB, the wider remit. But also, in Ruth's comment, I heard this, which is, what's our tolerance of hospital-acquired infection? It always used to be 0, but we're seeing commentary that feels as though that's weakening. And I don't think we should accept that weakening of that 0 tolerance. Sorry? Hilary.
Could I just ask one comment? Because I'm sat here thinking, every time there's an infection, hospital-acquired infection or health-acquired infection, everybody's doing review and they get bogged down in reviewing each case. And very often we're coming up with the same things. It's back to basics, isn't it? Is there something we can do in maybe a mini campaign, just reminding people what the basics are, from hand washing to good wound care dressing to, good catheter care. Because when people are when the system's really, really busy, we do see this. But what we're seeing here is a consistent level. We're not getting any leeway, are we? With E. coli and C. diff. So is there a role for the ICB just to have a bit of a mini campaign to remind people to take a minute to think about the basics of care? Just a food for thought.
Can I suggest that Chris liaises with the IPC leads across the system, and perhaps comes back to us to help us understand what is happening and what needs to happen. And we use our power of convening to support how the providers are working.
Well, when I've looked at some of the reflections in the report, it's jumping out to me around the basics.
Sure, I'm suggesting that what we do is,
of course,
we find out what's happening, and then we'll be informed, and we can then give a view. Okay, we're happy to move on. Can we go to the finance report, Claire, please?
Yes, thank you, Chair. So, presenting the paper in the pack today, which is the finance report to the period at the end of September, so for month 6, we are seeing a adverse variance to the plan that we expected at this point in the year, in total across our system of £56 million, of which 39 million relates to ICB position and 17.5 million relates to provider positions. You'll see in the paper that that is a continuation of the position I've reported previously around pressures associated with industrial action in providers and of excess inflation, particularly around prescribing and continuing healthcare costs in the ICB. Since this report was written, we've obviously had the plan reset work that we've been undertaking over the last 3 to 4 weeks, which Graham referenced in his Chief Exec report earlier in the meeting. And so just to verbally update on where we are as a result of those conversations and that national process. We've had announced as part of the £800 million national funding, we had an allocation of £41 million for Cheshire and Merseyside. We've also had an adjustment to the elective recovery fund requirements, which means for the same level of activity, we will receive an additional £17 million. So that's given us a £58 million additional resource to support the gap that I'm describing in this report. We also have had a period of rapid review of all of our programme spend, a reprioritisation, and we're in the process now of agreeing an updated financial plan with NHS England as a result of that work. So there'll be an opportunity for the board to talk about that in more detail, and we're still working through the implications of that. But I felt it was important just to let you know that things have moved on quite quickly since this particular report was written. The Finance Committee has reviewed the month 6 position in detail. We've also had a deep dive in the committee around the CHC and prescribing position over recent months. So as it stands, the forecast at month 6 was that we had some significant risks for the delivery of our position of around about £140 million. But with the recently announced funding and the reprioritisation of a number of our programme budgets, we are looking to get to a place where we can deliver a break-even position. But that will be subject to a follow-up paper for the board in due course. Happy to take any questions.
Thanks, Claire. Any questions? Neil?
Yes, thank you. I think the position is a good position. I think Claire's worked tremendously hard nationally and locally to get to where we are, and she's pulled the troops together to get there. So it's a good position. I think we were in this position last year when we talked about let's look at a tactical solution and what's the strategic solutions. And inflation and strikes have sort of pulled the rug from under. But we're here again looking at a tactical solution. We're here again looking at a tactical solution, which is an excellent plan with high risk, but I think is a great plan. But we've still not got the strategic solutions. If we hit the plan, and the plan disguises the fact, of course, that we've got 6 trusts with about £160 million worth of deficit. And that's not the underlying deficit, that's the in-year position. So I know a lot of work was taking place, I know with Rowan over the clinical strategy aligned to the financial strategy. But unless we find a way of addressing some of these underlying big issues, and it's not a finance issue, it's a service issue, we're still going to be here again next year with the same firefighting. And people talk about finance being a constraint. I know it is a constraint, but it shouldn't be a constraint of safety. Finance becomes a constraint when we get into big deficits because we do things short term. We don't have the long-term solutions. And we need to find some space within the team to start addressing the strategic issues that underpin some of these big local issues. I don't understand within the organisations which trusts can help themselves, which trusts can't help themselves, which trust can help others. We need to understand the context so we know how to put in the support and how to help organisations help themselves as well. So great for this year, big risk, I accept that. Job well done, but we need to start addressing that strategic issue. We'll be here again next year with the same.
Thanks, Neil. If I could suggest there are some matters that we'll need to discuss in the private part of the board, especially the detailed, at the detail level of our finances. But Claire, and a response to that overall ask.
Yes, I absolutely agree with Neil. We've started the work to look at the size of the gap, what's driving the gap. There is a paper due to come to the next board meeting around our response to some of the big pieces of transformation work and the geographies that we need to look at in order to bring partners together to look at the future clinical models and pathways for individual parts of our system that will need to be progressed to drive financial sustainability. So, you know, what is it that how does that look for Liverpool? How does it look for Cheshire? And what are the alternative models of care that we need to be considering in order to bring that together from a financially sustainable position? So I'll bring that, but as you say, Neil, it's not just finance, you know, colleagues are involved in that as well, so I'll bring that to the next meeting after Christmas.
Thanks, Claire. Is it worthwhile also saying that this, both nationally as well as locally, given the likely financial outlook for the public sector, for the NHS, there are some really, really difficult choices to be made about progress on some of the initiatives and ambitions that we have. And we'll have to have a look at that and understand in this public meeting how we're making decisions around that.
Yes, absolutely.
Yeah, thank you. Tony?
Thanks. So just picking up on Neil's point there about taking a longer term view of some of these drivers of deficit that you've been discussing, and Erica's points about continuing healthcare made earlier on. In your paragraph, your short paragraph on continuing healthcare, the overspend relates to increases to volume and price, the impact of inflation. And Chris mentioned earlier on the challenges of quality around continuing healthcare, the need to complete assessments and so on. What I didn't get from that, of course, because it's a very brief mention, is there a considerable variance across Cheshire and Merseyside of the pressures rather than the overarching one? That's the first one. And then the second one is, could we see something with a longer term focus in future, please?
Yes, so your first point, variation in continuing healthcare, certainly from a financial perspective, yeah, it's huge in our system. So across the 9 places, we have probably 3 that are potentially looking at between a 15 and 20 million pound forecast overspend by the end of the year each. And then probably another 2 that are not far behind, and then a number that are sort of not far off, you know, where they might need to be. So yeah, we've got a really high risk set of about 4 places on continuing healthcare, and the 2 Cheshires, Wirral, and Liverpool and Sefton to a certain extent follow closely behind. And that's work that we are, you know, the exec team has spent a huge amount of time thinking and looking into this over recent months with the place directors, and you know, we're considering what additional support we need to put in the short term to really get to grips and understand what's driving this. So that's a very live discussion over the course of the last 2 weeks as the month 7 position that we've not yet finalised or reported here, but looks worse again. So yeah, it is something we're concerned about.
Yes, thanks for that, Claire. I just recognise the challenge you have, because this has been on CCG finance reports for years and years, year after year. It's becoming an almost intractable problem to deal with, so I do appreciate the level of intense work that you're putting into it. Thank you.
Thanks, Tony. Steve?
Just on H2 reset forecasts on risks, you seem to be saying, if I've got this right, using 4.8 million from the current year budget to support the balanced position by moving money away from health inequality and tackling health inequalities. And then you go on to say that may be an issue that needs to be addressed in terms of the objectives we have for reducing health inequalities next year. Now, one of the objectives of this board is to reduce health inequalities. I just raise with you, why are we taking money away from that area when it's one of our key objectives, and prevention again gets to the bottom of the queue?
very good question, and one for the, I think the paper that you're looking at is not the one for this meeting. We're picking that up in the discussion later.
Okay, are we happy to move on? Got a paper here for noting. Clearly there's that strategic and variation issue that's been highlighted by our colleagues around the table. Thank you. Good report. Should we move on to the quality and performance report? Anthony?
Okay, thank you, Chairman. Board members will no doubt recognise the change in format of the report this month. It's the first time the board has seen it in this format, but it has been through Quality and Performance Committee twice subsequent to this. The design is hopefully one that provides a greater insight into the delivery across both provider and place as well as in aggregate, and offers a greater integration, I would suggest, in terms of other areas such as finance, workforce, etc. We've moved away from the narrative style of reporting. We've moved into one where we report by exception, to give more of an insight into the actions and timescales around areas of concern. And it's important to note that those exception reports are scribed by the lead officer or the lead executive from the ICB or the collaboratives, showing that ownership. There's probably a couple of areas I want to pick out. Clearly, we have that focus on urgent care, and I'm very conscious that we've got the winter plan paper discussion later on the agenda. But I think in terms of the headlines, it's clear to see that from a physical health metric point of view, we are already beginning to see the increased pressures around winter, as shown here. And whilst we may be faring favourably compared with some of the national deterioration, it's little comfort when we are well short of the standards. And probably the biggest draw out for us there is around our particular ambulance Cat 2 response times. And whilst there's a high degree of link across to ambulance turnarounds in the acute sector, it's not solely the one factor. And we know we've got some challenges, not uniformly across the patch, but certainly in some of the areas of Countess, Wirral, the Whiston site from within Mersey and West Lancs, and the Aintree site within Luft. And I'll touch on some of that later on in the winter paper. Our non-criteria to reside and beds remains the key focus in the run-up to the peak of winter, which is expected to be in January. But as I say, we'll draw more on that in a later discussion. In terms of the elective, if we look at that, our referral growth is very comparable with England, although our total list size growth is below. And that's a credit to the volumes of activity and some of the effort that Anne made earlier in terms of our productivity and efficiency, in terms of our good performance against ERF standards, despite that disproportionate impact of industrial action during the course of this year. The main challenges in terms of the key objective of reducing waiting times down to 65 weeks at the moment resides within the Cheshire and Wirral trusts. But again, the work of the collaborative is there around mutual aid and the offering of support and patient transfers, as well as the utilisation of the elective centre over at Clatterbridge. We are 4 months out, and it's clear to see that whilst the overall number of 65 weeks is not coming down, the approach that we have taken is one of a clearance approach. So that is one of, you know, if I only shame to drop into a level of detail, that's one where we look at the total volumes of patients that could exceed 65 weeks by the 31st of March, and we tackle it in that approach. And we would expect to see a sharp decline now in the number of over 65s between now and the year end. There's a good governance and performance framework and support mechanism around the delivery of that, with every Wednesday, with all providers in the room, doing that granular level of micromanagement around the elective, and we see that every week, and we're on weekly trajectories, run rates, and scrutiny around that. So at this point in time, we notwithstanding some of the issues that we may talk later about the financial reset, we still stand in a good stead for achievement of that, and we certainly stand out very, very well in comparison with other ICSs around the country. One point that I really do want to draw out is our cancer backlog reduction. We are now at a point where the volume of patients awaiting treatment or on a 62-day pathway is now below pre-pandemic levels for the first time, which is a great achievement, again, through that almost holistic view of a single waiting list for Cheshire and Mersey. It's really beginning to pay off. And therefore, as we've now dropped below that backlog level, we expect to see the delivery of the performance standard, which is the number of patients treated within 62 days, occurring during Q4. So that's a real credit to the way in which the system has worked, and it is something that, even through the depths of winter, even through the depths of some of the financial challenge, it's very much protected, and we expect to see that delivered with a high degree of certainty. So I'll pause there if that's okay, Chairman. I'm conscious that there's a lot of detail within the paper. Lots of people around the table are able to answer any questions if it's not already provided.
Thanks, Anthony. Any questions or comments? Neil?
Thanks, Sandra. These are great. Really, really helpful. Just a couple of observations and understanding again, and I keep asking this, and I lose the plot for myself sometimes, and that's about patients no longer needing residents to stay, and that's on page, I think, 155. We've got a lot of hospitals there with sort of high performance, 20% shown as green. Mid-Cheshire was 19. I just wonder why they're shown as green when they've got such high levels. And I still don't understand why we've got this problem, because it's like having a hospital full of people who don't need to be there. And I think in the winter plan you say you've got a target of 12.8. Well, why are we still at 20%? And how are we going to get to 12.8? Because that would solve so many problems in terms of winter pressures, elective recovery, productivity. Why is it such a stumbling block?
Well, I think it's, it's absolutely multifaceted. I mean, to answer the easy question around the greens and the reds, in terms of the RAG rating, when we developed the operational plans for this year, Place set a particular ambition to try and achieve 12.8%, which was very much in line with the national high achievers. That nationally it runs, probably around about 16%. But I don't think the confidence was there from entirely across the provider patch, and therefore trajectories were submitted that were of a higher level. So actually that we have exceeded the provider expectation. And if we look at the total volumes of non-criteria to reside today, which is 1,054, that is below the 1,200 that we had at this point last year. So improvement has been made, but not of the scale to make a tangible difference to the way in which urgent care flow is operating across the system, and it's nuanced across individual providers and places. I think Steve would talk very eloquently about the challenges that affect social care, and I think in terms of capacity. So it's one that we are working on, but it's still working in some spaces, place by place, provider by provider. And what we need to move to is these standardised models of how we do the discharge processing, understanding of capacity and demand, that already exists, and where we need to go to in a more mid-term in terms of a strategic commission. So there's a lot of work around that, but at the moment it is just painful grind. It is just about that focus day by teams to ensure that patients are leaving hospital faster than they expected and placed in the right setting. And some of that stuff that we saw earlier on around virtual wards is part of that. It's avoiding admissions and also allowing discharge. But there is no easy answer to this one at all.
But elsewhere they've got answers. I mean, we're an outlier. So why are we such an outlier? I think Hilary wants to come in.
So we have been an outlier for many, many years.
Yeah.
And part of our understanding is, do we have capacity and demand properly understood in that transition from health to social care? Do we understand whether or not we have discharge policies that are more effective in one area than the other? And that's the bit that we're trying to overcome at the moment without any real strategic solution to it right now.
Great report, Anthony, thank you. What I'm curious about, I can never really see what's going on in community services. So we've got the 2-hour response. And I don't know if this is something we should be looking at the ICB, but at Place, do we have enough reablement rehab services? Because if we don't, that could be contributing to the long residency in acute. And also, how long is it taking to do CHC assessments as well? Have we got people in hospital beds awaiting CHC assessments? So I think that then maybe broadens our curiosity about why people are residing too long, but also extends the review of CHC as well in terms of what's impacting on the variation. So there's something about me, how are you investing enough in reablement? That's the difference sometimes between people needing a CHC package or not, if we can reable them quite quickly. And secondly, it'd be really interesting, therefore, to have the CHC metrics on here as well. So the 3 senatorial metrics, but also the metric of how much are we spending on independent reviews for CHC? And that may help us understand whether our own CHC teams need more clinical support to make the right clinical decisions. Yeah. Thank you.
And I think Claire might come in on the CHC and the approach that we're taking around that. But certainly I think your point around, do we believe we have the right reablement capacity? I think it's fair to say that at this point in time, we don't have that granular understanding place by place, provider by provider. What we have is historic commissioned levels, which are rolling forward. Now we have specific work taking place within the Liverpool system and the Warrington system right now, where that granular level of capacity and demand is being provided, which is part of the support that we have received from our Tier 1 status for Cheshire and Mersey. As part of that, the team that's doing that has agreed to do a light touch approach to that in every other part of our system, but it's about taking the understanding of that and rolling it out.
It just seems funny we've got granular detail on virtual wards and we're underspent there, but we haven't got it in these crucial services that could answer some of these questions. So, yeah, thanks.
Sorry, Anthony, it's continuing the same thing. I suppose a request from me, I can see how we want to try and average at 19% and all the reasons. Is it possible to have a slightly longer term view perhaps for the board that shows what we think will be impacted by improved community, improved virtual wards, home first, because I know that was mentioned in Graham's update that came round to us. It might give us a clearer forward view of what our expectations are and how we get to a more reasonable percentage. I know it's very, very difficult.
It is very difficult, but it's part of the processing that we do on an annual basis to develop the operational plans. So I could fetch something back as a separate paper around the build-up of those 9 place plans into what we expect the impact to be from each of those. Sure.
Overall, hugely important point to us.
So, look, this is the single biggest issue that I think will determine whether or not we have the safest possible winter and we're able to care for our patients in a safe and appropriate way. I think the challenges and the questions the board are asking are the right ones, yeah, but this is a deep-seated and complicated problem. We've had national reviews come in. As Anthony has just said, we're having a detailed piece of demand and capacity modelling work done in Warrington and Liverpool. You asked quite rightly about bringing the CHC figures alongside this. Now, if we go back to the CHC point, we had 5 different ways that CHC were being managed across our 9 places. Yeah. It takes time to unpick that and get that into a standardised place. But in aggregate, and Hilary, I haven't seen this down at a granular level, but in aggregate, we have more people going into CHC assessments than other parts of the country. We have less people converting to CHC packages, which is a product of too many people going into the assessment process, but our spend in average compared with other places is higher. So that implies that more people are getting through and getting packages. So, you know, a high failure rate through the assessment process is not that we are rejecting people who should be getting those packages. The numbers don't bear that out. And then to Erica's point, we have granular bridge diagrams to what good would look like that attempt to link all of these things together and back to sentinel metrics such as A&E in our winter plans. They are very detailed, they are very granular, but they are also very, very difficult to deliver. Yeah, and I think this also goes back to, this is why it is right for Steve and Raj and Claire to have had the conversation earlier this week or last week about how do we get into a space about having a conversation about the long-term sustainability of the social care system. Our local authority partners had a lot of extra money this year to stabilise the social care system, to increase the rates they were paying, to enable fair rates to be paid to social care providers, to stop the number of social care providers falling over and exiting the market. The local authorities had a second tranche of money, but not announced until I think something like the first week of November, to allow them to buy more capacity through this winter. That hasn't kicked in yet. So I think the board is right to challenge it on this. The board is right to be worried about this. This is the single biggest issue that will affect whether they have a good winter. But there are also positive things taking place, and there is also more financial capacity in the local authorities to buy additional capacity that hasn't come through yet.
Thanks, Graham. Anders, do you want to make a comment on this issue? I'll bring you in.
Yeah, of course. At risk of kind of raising this every meeting, you know, we are in still November, and yet we've got probably the worst situation we've been in for a long time in terms of the pressure on bed capacity in the acute sector. So, you know, I always think it just helps to kind of turn it into a picture, but your average, you know, site with an A&E, you know, so take the Wiston site, for example, you know, so we've got 30 wards and 6 wards of those patients are full of people who don't actually need to be there. And when we were talking about infection control before, you're right about that basics thing. But the other thing is, when you've got all these people being nursed in A&E and being in corridors and, you know, and the general stress that's on the staff, you know, you're not going to get the basics done right when you've got that going on. And you've got that thing about patients who really shouldn't be being exposed to infection before we've even had a chance to triage them. So there's no spaces in A&E because some of those 6 wards are actually in A&E departments. So we're not going to solve all these problems until we get into a better place on this. I'm just a bit worried that we're not even in the peak of winter yet. And things are so bad as it is now. Patient experience is dire, the staff experience is dire. It's not helping with staff recruitment and retention who would want to do that. So, you know, everything that's going wrong really is, a lot of it is down to just sheer pressure on the system. And we're not even at that point when we'll be at the worst we'll be at. So it is just a plea that, you know, all of those numbers that you look at them, all those red numbers at the beginning of that performance report about holding ambulances up. I mean, we hate holding ambulances up. It's the worst thing. You know, if we think it's scary in A&E, it's much more scary to be at home waiting for the ambulance when you need that help. So we all get why we don't want to do any of this, but we're just absolutely inundated with activity that we've got nowhere to put all of these patients, and it isn't where we need to be at all. So I'm absolutely agreeing with Graham that it is the absolutely most important thing for us to solve, because so many bad things, you know, flow from this one very bad thing, and we're just not making the progress we need to make, because, you know, we've been stuck at 20% for an age, haven't we? And, you know, the worry is that we enter winter in the state we're in now with occupancy over 100% kind of everywhere, and you know, it could only get worse than this. So we could do with something that shifts the dial a bit before we get any closer to what will be the worst period.
Okay, we're covering the stuff that's in the winter plan, and I'm going to suggest when we get to the winter plan, we shorten that conversation because we've covered an awful lot of the issues here. Can we move off this no criteria to reside issue, as important as it is, and we'll need to understand how we can take forward some of the initiatives that have been articulated, both in the plan and also by Graham and Anthony. But I also was going to make a shout out for primary care because you're suffering the same sort of pressure. So we know it's the whole system. And Steve, very quickly, I'm just conscious of time.
Oh, well, just to reassure Neil that every day, daily, there's a relentless focus, partnership, multi-agency focus on no right to reside. A lot of creativity goes on every day. Numbers are given in the 9 places about the problem. Yes, we may be an outlier. There's very complex reasons, but we are finding really some creative solutions to it. And it's not as though, you know, this matter's not top of the table. On the point, Graham, about the council given a lot of money to provide additional support. We weren't given a lot of money. Consider some of the numbers of heard here today about intervention from the Treasury for the NHS. It's small beer. Didn't even cover the cost. Give an example from last week. The budget statement gave 9.8% rise to the national living wage. Really good for low-paid workers. A lot of those low-paid workers are in domiciliary care, in care homes. Those providers will be coming to councils expecting a rise in their contracts. That's money this council, the councils don't have. That gives an example of the sort of problem we have in terms of trying to deal with no right to reside.
Thanks, Steve. Mark.
I'm happy to leave it, thanks Raj, and we can pick it up under the winter plan item.
Thanks, Mark. Steve, you've done your point, I think. Simon?
Winter plan, Chair. Covering the winter plan.
Okay. Ruth?
Separate points, thank you, Chair. Looking at the health inequalities exception reports, children and young people access to mental health services is one of the commonest issues that charities are raising with me whilst I've been visiting them on Merseyside this year. I see the report says we're making improvements. My question is, will we hit the target for March 24? And on the blood pressure management, there's wide variation in fact, on both of these measures. But I was a bit concerned to see that our ambition is 80% achievement of target by 2029. So, and the explanation says the action is that we're not scaling interventions to the level of need. There's certainly 1 or 2 areas that are really way behind others. I just want reassurance that we're taking action that's going to get us much more progress and that we're not sort of just waiting till 2029. I should also comment that by saying 80% achievement, we're in building 20% inequality in our plan. Because really everybody should measure their blood pressure. So that's a separate point for another day. But just on those 2 points, please.
Ray, is there any comment you could give now on those, or should we come back?
I might look at Fiona or Naomi just to comment on how the blood pressure sits within QOF now and how that's picked up.
So within we do have targets within QOF. We've also got the PCN-DES that covers blood pressure targets. It specifically looks at patients with different demographic levels as well, and varies on that depending on, and one of those impacts is patients with significant health inequalities. I think within the targets there also has to be a level of understanding that some patients just don't want their blood pressure checking, they don't want to come in, they don't want a machine at home, and I think sometimes that's not represented when we're having these discussions. So it's actually really difficult sometimes to get patients to engage with our system. Now, I suppose from my perspective, how do we change that system then so that patients are able to engage, particularly patients who are already from live complex lives. So I think from a GP perspective, yes, the target should be 100%, but I think that we need to be realistic, and actually there are a certain cohort of patients who just do not want to engage with that.
just quickly come back. I absolutely understand that. However, we should not try. I'm just concerned that the time frame is so stretched that I want reassurance that we will see improvement in some of the lowest performing areas by the end of this year. What expectation of improvement do we expect, so we have something that we can monitor against?
So this is it's a cumulative measurement up until the end of March this year. So practices should be aiming to be on target to reach that by the end of March. So we have the 12 months to be able to reach those targets. Different practices bring patients in or engage patients in different ways. But a lot of practices are having to change the way they work in order to be able to meet these targets. And I think, there is significant, is pressure the right word? Yeah, there's significant pressure from place that we are expected to meet these targets by the end of CWAF year.
Just in your broader point, Ruth, as we go through planning for the new year, we will have to make some choices about priorities. And I think that's the point of time we should have this debate about where we put most attention and resource or not. So I'm going to move us on, but any comment about mental health, or should we come back on that position?
We'll come back with a detailed answer outside the meeting, except to say demand is rising, and demand is rising very significantly. And at this point in time, we do not have the services or the service capacity in place to respond to that demand. So again, it's a long-term challenge for us to address.
Thank you. Sorry. Please, last comment. I'm going to have to move on.
I was going to save it to later. Sorry, it's a really practical question. Are we going to see the Cheshires split in some of this data anytime soon?
Yeah, absolutely. The plan is to do that. The problem we've got with some of this stuff is that it's a 12-month rolling target, and as such, in some respects, we've still had submissions under the old CCG footprint. But we're working on the split of that, and similarly the split of the individual sites for both Mersey and West Lancs trusts, as well as the breakdown of the Luff sites as well, so that we've got that granularity.
Okay. Thanks, Anthony. Thanks, Louise.
Right, sorry.
I'm going to push us on.
Okay.
And we're running out of time. Sorry. Firstly, the move to the different presentation of the indicators is really good, Anthony, and I think that's helped us understand better and resulted in lots more questions. So it's good. That does its job. So thank you very much, sir. A number of significant areas I'm going to highlight. No criteria reside. We'll talk about winter plans shortly, but more briefly. But this question about understanding, the deep root causes of why Cheshire and Merseyside is such a variance on, if you like, the tip of the iceberg around no criteria to reside. Going to move us on to the committee highlight reports, but seeking from chairs of those committees just to say a few words, and then because the report are pretty full. Tony?
Thank you, Raj. I mean, the report is very detailed. It's under the new format, which I think is extremely helpful. I'll just make a couple of comments on maternity. While we saw some improvements in triage delays, we're recording concern over delays in care, particularly inductions of labour, and expect to see a report that unpicks the impacts of workforce at the next committee. That does appear to be the root cause of this challenging area. The second one, we received the Children in Care annual report, the first one we've received, which was a very well received report. It was excellent in its detail and its representation of the challenge. It's left us with a considerable number of questions to be asked about how we improve the health care and support given to children in care. So I'll rest at that point, Raj.
Thank you, Tony. Are there any urgent critical questions the board wants to ask about this report? Otherwise, it's here for noting. Thank you. Erica, primary care.
There's two for me, isn't there? There's finance and primary care first.
Yeah.
Okay. I'm going to take 1 minute from you now, even though you won't like it, because we've got some really good news within primary care. Okay. I am going to hand over to Ian, because it's a preventative piece of work, it's oral health, and I think it is something that you'll all be pretty proud of that we've been able to do across Cheshire and Merseyside.
Thank you. So at the Assistant Primary Care Committee, we took, obviously, ICB have inherited responsibilities around dental, and it's some challenges around that which we're working through. But what can we do to be getting upstream? And sadly, the main reason for admissions in 6 to 10-year-olds is around tooth extraction, which is just horrific, really. We know that our oral health improvement responsibilities sit with our local authority partners, and what can we do to get upstream and help try and tackle that demand as well, as the impact that they can have on the best start in life, loss of school days, etc. We also know that you're 3 times more likely to have dental decay in the most deprived areas than the least deprived areas. So we put forward a number of proposals to the System Primary Care Committee. I'm glad to say that we're looking to introduce a 3-year supervised toothbrushing programme targeted to 2 to 7-year-olds in our most deprived communities in all of our 9 places. Approximately, that's about 67,000 2 to 7-year-olds we're looking at working with. Really important to we work with our local authority partners and our community sector on that, thinking about the relationships with our school nurses, health visitors, early years settings, and there's a really strong evidence base that around that as well. So we're mobilising that through our Beyond group that you would have been aware of. It's another NHS Core 20+5 indicator that we're working on, really looking to mobilise that all from the next financial year, but putting that planning in now. Recognising not all that reach might not be possible for all that age group, we are looking to provide free toothpaste and toothbrushes to targeted areas as well. So that would be things like through our food banks, the community hubs, family hubs that we do. So it's a really good start, I think, and a really signal shift about working together as a system on prevention and getting upstream with that.
Fabulous.
One more thing that I just do want to add, though, that also the committee have got a very watchful eye on the provision of dental services across Cheshire and Merseyside. So the first full order internally comes after we see 6 months of data. So the first thing we'll be doing is red, amber, greening that, and then we'll be coming to you with any issues, challenges, and hopefully some good news stories as well. So that's it. Thank you.
Thanks, Erica. And you're asking us to approve the terms of reference?
Yes.
Yeah. People happy to approve those terms of reference? Erica, Finance?
And Chair of Finance, just be assured that we are forensically investigating everything that's happening within Finance, and we've got a discussion later. I don't think there's any more to say on the Finance Committee. I'm happy to take any questions, but thank you.
Thank you. Should we move on to the Board Assurance Framework? Claire, you're going to head this up?
Thank you. So the establishment of effective risk management systems is key to successful management of our organisation and the wider NHS. And it's fundamental to good governance. To remind the Board, we approved the 2023-4 Board Assurance Framework and Principal Risks in May this year, and we received an update on Q1 Board Assurance Framework in July. The principal risks are those risks which, if realised, have the most significant impact on the delivery of the ICB's strategic objectives. So we have 10 principal risks. 4 are scored as extreme, which is 15 plus, 5 high and 1 moderate. And these 4 most significant risks are outlined in 2.2. I think we can all, myself and colleagues around the table who are the lead directors for those, can answer questions if we get to that point as well. P6, which is around primary care access, we probably can cover that, Raj, in the item later on the agenda. Other areas of note are the amended risk descriptions for P3, changes to current risk ratings for P2 and 8, and increased scores for P6 and 10. The P is the principal, so in terms of principal risk 2, just to be sure. Section 9.4 details the work that's been taken place in Q3 to strengthen the controls of our BAF risks. This is considerable, and I think it's an opportunity to recognise the number of key areas of work that's taken place. Further assurance to the Board is the reconstituted ICB Risk Committee, which is chaired by Graham, Chief Exec, and attended by all the directors, place and corporate. It reports through to the Audit Committee and provides an opportunity for check and challenge and consistency of approach and how we manage risks across the ICB. I'll finish there, conscious of time, but obviously open up for questions and comments, and obviously colleagues around the table can answer those too. Thank you.
Thanks, Claire. Board Assurance Framework is probably the most significant document that the Board holds. It's comprehensive and detailed, and it obviously relates to lots of other documents and pieces of work that the board undertakes. I've always found it really hard to discuss the board assurance framework in this type of format because it's so comprehensive and detailed. So you can take from that a signal. I think we should look at, are we confident that it's developing in the right way? Are we confident and assured that the systems and processes that inform the board assurance framework with the pinnacle at the risk committee is working as effectively as it should at this point in time in our establishment as an organisation? Tony?
Yeah, if I could please, Raj, just to comment on what attracted my attention is was the risk P6, but I'm not going into that in any great detail. What I like is the way it takes you through the process of identifying what exactly is the risk in primary care in summary form. So I do appreciate that. We can then look, when we get more detail, at it in the performance report. So this, for me, the board assurance framework, alongside the performance report, is how we bring together our understanding and plans to reduce risk in the system. So I think it's a very good balanced approach.
Thanks, Tony. Any other comments on process document? I am going to ask, does anybody need any clarification of the controls or mitigations that have been put in place for these top 10? Okay, thank you. Fiona, can we go on to the Women's Hospital Service Liverpool Programme Governance Refresh, please?
Thank you, Chair. So the paper in front of you today is asking the board to consider and approve revised governance arrangements for the Women's Services in Liverpool programme. The Women's Services Committee was set up in February of this year, and up until now has been undertaking both programme planning and delivery and programme assurance, so both roles. We appointed a programme director and an independent clinical senior responsible officer, and those fresh pair of eyes encouraged us to look again at this. And then in August, the interim chief executive arrangements for Liverpool Women's Hospital Trust were confirmed, and a conversation ensued about us being very, very clear about who was responsible for what, who is doing what. So that resulted in the chair, Raj, the chair of the Women's Services Committee, asking us to undertake a review of the governance arrangements. So section 2.5 in the paper outlines the resulting proposal for a separation of the programme planning and delivery element from the assurance element. So that will see the Women's Services Committee taking on the assurance, or continuing with, rather, the assurance and oversight elements of the role, and really focusing on the bits of the major service change process that are commissioner responsibilities. And then we will be establishing a new programme board, which will do the developing of the case for change, the future model of care, and any associated options appraisals that we might need to do. The programme board will report to the Women's Services Committee, and will also report to the public boards of the providers, the 4 main providers involved in that programme board. The paper also mentions a system oversight group. For completeness, it is not part of the formal governance of the Women's Services programme, but it is part of our quality governance architecture to look at the more immediate quality improvement plans following recent CQC and other reports. The overall approach that we are proposing to take is a risk-based approach. So the programme board and the Women's Services Committee will be very much focused on the medium to long-term risks and the mitigations for them, whereas the System Oversight Group will be focused on the more immediate risks and short-term solutions. My recent conversations and observations with the clinical and executive teams of both Liverpool Women's Hospital and Luft have demonstrated, for me anyway, a really genuine desire to work in partnership to optimise safety at both sites. So this means making services as safe as possible where they are now, as well as considering how we improve safety and sustainability in the longer term. I think there is a growing awareness, and I think it is a good thing, of the risks that particularly pregnant women face when accessing services at other sites, non-Liverpool Women's Hospital sites in the city. And this partnership approach and the revised governance, I think, will allow us to address that more comprehensively. Section 14 closes the paper with our next steps and what we're asking the board to approve. But I just wanted to add what's not in the paper is that to reassure the board and the members of the public that we remain absolutely committed to ensuring that the public are kept informed, and that people with lived experience are an integral part of our conversations, be that in the case of change, be it at the programme board or our options appraisal. We are continuing to explore the optimal way to involve the public in that. So once we have confirmed our new governance arrangements, we'll be able to then make progress with making sure that we've got that absolutely right. Thank you.
Thanks, Fiona. Anne?
I suppose I'll just look for a bit of assurance from Fiona about when you make decisions around a tertiary provider, it obviously often affects the other providers, and obviously there are no other women's services providers on that list of the inner sanctum of the Liverpool Trust that will be reported to. So, that kind of knock-on effect to others when you do something with a service, it's really important that we take that into account. And also, the population side of it as well. Obviously, how it affects population flows and things like that is also crucially important. Now, I know the geography of Liverpool, it's all a city, isn't it? So it's not one of those things whereby if you shift something, it should change the patient flows, but it may affect what services are available, where and whether or not we need to be. If we're on an over-centralised model, should there be some things that could be actually provided more locally? All these kind of considerations, as well as the kind of quite inward-looking thing about let's just make sure all the trusts in Liverpool have got the kind of input into the review. So how are we going to make sure the rest of Cheshire and Merseyside views and needs are taken into account?
Thank you. So I think the revised governance actually will help us to do that more effectively. So the programme board will be very much focused on the within Liverpool element, but it will be reporting to the Women's Services Committee, where CMAST and the wider system will be members of that Women's Services Committee and in attendance there. So that is where the Women's Services Committee will has that responsibility to consider the wider system and wider stakeholders.
Excellent. Graham?
And I would just remind the board, if the work of this committee were to recommend service change, that will be subject to substantial engagement and consultation.
Thanks, Graham. So if we could move on, the board, the board has been asked to approve the governance proposals that are in this paper. Can I seek that approval? Is that a yes? Thank you. Going to go into national... right. Have we... Matthew, have we got... Yeah, okay. So we have got in the fortunate position where Louise Shepherd, who has two roles. One is the Chief Executive of Alder Hay. Hi, Louise. And also the National Director for Children's. I'm probably saying the wrong title there, Louise. Apologies. Who's spending 20 minutes with us to give us the benefit of her wisdom and some understanding of what the national picture is, and perhaps even some comments about Cheshire and Merseyside. And I think you're doing a presentation for us, Louise. I think you can't see us, but we can see you at the moment.
Can you hear me, Raj?
Just 1 minute. Can we just test the sound?
Can you hear me?
We can hear you.
Oh, brilliant. That's great. Thanks very much. Well, I can't see you, but thanks so much for giving me the opportunity today, Raj and Graham. Really appreciate it. It's a great chance to just share with you some of the work that's been going on. If I just launch a presentation and keep my fingers crossed and hope it works, can I just do that, please? You starting to see that? that come through?
Yes.
Brilliant. Okay, thank you so much. Well, first of all, sorry for not being with you today. I haven't taken my own advice and failed to get my COVID vaccination, and have succumbed to the gift that keeps giving. So I'm really sorry to not actually be with you in Macclesfield today. But thanks anyway for being able to join you online. Just wanted to share with you, I guess, a little bit of the work that's been going on since I was appointed to the role, the national role that Raj mentioned, which was described as the chair of the Children and Young People's Transformation Board. And I started at the start of this sort of financial year in earnest. So I've been at it for about 6 months. And it's been a fascinating journey for me. But if I just share with you that the main objective that I was given was to have a look at what's been going on with regard to how the long-term plan for children is being delivered, but more importantly, possibly also say, given what's happened with the pandemic, what we know is happening with children nationally, and some concerns starting to be really raised about that. What should the remit of the programme, the board, be? What should NHS England's remit be with regard to children? And how should we be working as part of the new NHS England, and with, of course, colleagues across the country to refresh the approach? So I thought it might be helpful today, Raj, if I just shared with you some of the work that we've been doing, that we've shared with the national team. In fact, there was an update just done this week. I'll share some of those slides with you about what the issues are impacting children nationally, and what we're doing to revise our approach nationally. And then, as you said, show more importantly perhaps how that links with what's going on locally in CNM, because there's some brilliant work going on in Cheshire and Merseyside actually, and which I plagiarise shamelessly in supporting the work nationally, because there's so much learning to gain from what is being done locally, and it is all about what happens at local level at the end of the day. So it's a big thank you to colleagues locally who've helped me on this journey as well. So if I can just start by painting the picture if I can, and I'm going to share with you some slides that we've pulled together in the last 6 months, because you won't be surprised to learn that nationally there wasn't much data. In fact, there was very little data about what was happening to children, because we don't look at data in that way. We haven't done traditionally in the NHS, so we don't look at it in population terms, do we? So one of the things, the tasks that we've been trying to do is make sure that we've got that data together. And it's clear from the data that children's outcomes have undoubtedly worsened in the last 5 to 10 years, sadly. And particularly inequalities have widened. And there's probably many reasons for that. I'm sure there'll be a million PhDs written about it, but I think you can possibly boil it down to 3 things really, fundamentally. One is all around poverty, frankly. The number of children now living in poverty has increased in the last 5 to 10 years. We've now got over a third of children nationally living in poverty by the national definition. That's over 4 million children. But 48% of children from a black and minority ethnic background live in poverty. That's undoubtedly impacting on their health, and you can see that quite clearly. Austerity has had an impact. The safety net and the universal services that used to support children and families have been really severely affected, which we all know. Early intervention services have been badly impacted. If we think about local authority budgets, they've gone down, they've pretty much halved in the last 10 years, in the last 7 years in particular, actually. So they've come down from 3.8 billion to 1.9 billion today, and we've seen a 22% rise in the number of looked after children nationally. And then the third thing is the pandemic, of course, which absolutely exacerbated the situation. And what we saw in the pandemic was, which we've all recognised locally again, was a huge increase in the number of mental health presentations amongst children and young people. They've gone up from something like 1.9 in 2017 to 1 in 9, children with presenting with a mental health condition in 2017 to 1 in 6 today. Early years development was hugely impacted. We've seen a huge increase in the number of children presenting with neurodiversity issues. Don't fully understand the reasons for that, but certainly developmental delay has been massive. And at the same time, with the pandemic, we've seen access to services really get shattered in many places. So we've seen huge increases in the number of children waiting for speech and language therapy services. The number of health visitors has declined quite dramatically. Primary care has struggled to cope with children, to support children in the circumstances and pressures they've faced, and so have hospital services. So what you can see on this slide is a real kind of summary of the impact that that's having on children across a range of services and across a range of issues. If I just quickly take you through the slides we shared with Amanda and the team earlier this week, these are some of the slides around childhood mortality, which is absolutely on the rise overall. The CMD data is showing that very clearly. It's interesting where that's happening. I won't go into the detail now, but there's some really important learning for us about what's happening where and why. There are some really, we've seen this locally, some massive, this is the national data for presentations at ED for children and young people. So children under 16, the blue line at the top is the numbers presenting at the front door nationally. The yellow line is actually the number of admissions, which you can see has pretty much flatlined during this period. But what has happened and what's changed dramatically are the sheer numbers of children presenting at the front door. And what you can see from this chart is, again, a national picture where all these children come from, most of whom, on the left-hand side, are self-referrers. And what we think's happening is that many are not either finding the access into primary care or choosing not to do that. And many equally are potentially using NHS 111, but not actually then relying on that service to make a decision about whether or not to access ED. So we've seen huge numbers rise, but as you can see on the right-hand side, very, very many of those simply get sent home, 73%. And we know that that happens locally too, and we can certainly vouch for that in Alder Hey. The impact on PICUs has been pretty traumatic as well. So we are running PICU nationally is running at around about anything between 97 and 100% all of the time. And we're quite worried that we're going to start seeing very long distances travelled again for infants and children who need to access PICU services, given the pressures on PICUs. In the elective service, we've seen children struggling to get access to elective services and not being prioritised, frankly, compared with adults. So this was picked up quite early on, actually, and there's a lot of work being done in this space to try and ensure that elective waits for children are prioritised, if you like, in all age trusts just as much as they are elsewhere. The top line is the children's figures. In other words, they're the numbers of children who've changed, the percentage changed since 2022. The really important message from this is we're still seeing high numbers of children waiting over a year, and that number's not coming down, and again, nationally, and there's a lot of concerted work needed to be done to tackle that. I won't bore you with that slide. Wanted to highlight in particular the community waits and the challenges in community services. The top two figures there are the national numbers waiting, and we think these are underreported. The top line is the community paediatric service, which is essentially almost entirely autism assessment and ADHD assessment. Huge numbers of children waiting, and the figures are rising. And the second one is speech and language therapy, which again, where we've got huge numbers of children waiting and the numbers rising. I think we're acutely aware of what's happened with mental health. This graph shows what's actually happened for children versus the plans against the long-term plan target, where there was a plan to increase the numbers of children accessing mental health services, which was hugely welcomed. And you can see that by March 23, great efforts have been made across the country to achieve the long-term plan targets. The problem with that is that's probably only half of the number of children now who need the service. And so what we've seen happening across the country is huge waits for children trying to access mental health services. And again, we've seen that locally in Cheshire and Merseyside. Again, a massive discrepancy between the numbers of kids in care, the numbers of kids from a poor background, a minority ethnic background, needing to access mental health services and not being able to. Just in terms of some of the long-term conditions that children, you know, the big long-term conditions for children, we've seen a lot of work's been done actually on asthma across the country as part of the long-term plan to try and reduce the number of kids accessing asthma services. But you can see here that although we've achieved quite a lot nationally, relatively speaking, there's still a huge discrepancy in terms of the poorest children. You know, we're seeing huge numbers of children from the poorest communities still presenting with asthma. And we're also seeing that in these two areas as well, which are massive problems for the country. We now have 2.5 million children in England who are officially overweight, 1.2 million of whom are classed as obese. So huge issues there, and huge issues also sadly still in dental services, where the number of kids presenting with dental decay has been on the rise. It's absolutely shocking, the difference between the most deprived areas and the least deprived. And you can see there the oral health survey of 5-year-olds in England showed nearly a quarter of kids under 5 in the country have dental decay, which is completely avoidable. So, that's a pretty grim picture, but it's important that we've actually got it all together. Most important thing is what are we doing? What are we doing about it? So let me just share with you nationally what's going on here. When we first presented this to Amanda and the team in August, at the end of August this year, there was an agreement that about a number of things. The first was that we needed to join things up. We clearly need to take a population health approach, and we need to join things up across NHS England, because you won't be surprised to learn that just like so many of us in our own worlds, NHS England is no different and very much does work in silos. So we've got lots of programmes doing lots of worthy work, but not necessarily joining up their approaches. So there was an agreement to bring together a cross-organisational board for children and young people. And we had our first meeting in October, and that's now the board that I chair. And we report to something called the Strategic Delivery Committee, which is basically the committee that Amanda set up to oversee delivery of key programmes across NHS England. And it's chaired by a guy called Steve Russell, who's the Chief Delivery Officer. And it's them we presented to earlier this week. And you can see the priorities that we've agreed together. So this was all of the programmes coming together in one place in October and agreeing what the top priorities are for children and young people going forward. And I don't think any of those will be a surprise to anybody in Cheshire and Merseyside. And I'm hoping that they are hitting the mark for people around the country as well. That's certainly the feedback that we're getting from colleagues. So we clearly need to focus on continuing to recover children and young people's services, but crucially, transforming community services. They are absolutely critical to children and young people and their development and their well-being. And we're really struggling at the moment to deliver the services that they need. We need to continue to focus on mental health and long-term conditions impacting children, and of course the whole issue around obesity and excess weight. There's a big push around managing demand within urgent and emergency care, and a lot going on this week, a flurry of activity going on this week around that for this winter. Sort of what can we do to support communities across the country to support children and keep them out of hospital, ideally never touch an ED if possible, to achieve that at local level. And then there's a whole system approach needed, we feel, to improving health outcomes, which is around a population health approach to children and young people. So I could talk for ages about some of these things, but I won't go into a lot of detail other than to perhaps just highlight this particular urgent work around the UEC programme. There's an option and an opportunity to develop pilot work that was about setting up a paediatric 111 service, because one of the things that the pilot showed very clearly, where it was done in a number of places, including in the Northwest, was interestingly, when parents access a paediatric 111 service, they take great heed of the paediatric advice they get. So what we saw compared to the normal 111 service was that 60% of parents who access a paediatric 111 advice service actually don't take their child into ED. whereas the figures for just the normal national 111 services, only 20% don't take their child in. In other words, the other 80% do anyway. So we think that's got a big intervention that can make a difference if we can get that set up. And there's a lot of work being done to really spread and scale up advice to children in the community. And the big thing that I wanted to highlight there as well is we're pushing really hard to get the RSV vaccine commissioned, which is proving quite a challenge, believe it or not. But anyway, we're still pushing really hard to get the RSV vaccine commissioned in time for next winter. I won't dwell on these given time. Just on this slide, I want to just pick out one thing on here, which is this top point in the middle around care for kids with neurodiversity. So kids with autism and ADHD, which frankly is a pretty chaotic picture across the country and a huge need. So again, on the back of the work that we've done nationally and working with the executive team at NHS England, there is now an agreed national programme which brings together all of the main programmes, working with us around how we tackle and transform services for kids with ASD and ADHD, and bring in the whole issue around speech and language therapy. In other words, how do we support children with their early development? And there's a lot of work being done with a number of pilots that show very clearly that by working really closely with local authorities, we can make a transformational difference in that space. But it will require a completely different approach, a non-medical approach, you won't be surprised to learn, to tackling these issues and supporting children and families with them. So again, watch out for that, because that will be coming down the tracks. And again, we've already started some work in Cheshire and Merseyside on that. So that brings me to our lovely Cheshire and Merseyside, and I just wanted to say a couple of comments about this. As I said at the very beginning, you know, I think colleagues across Cheshire and Merseyside have worked brilliantly together in this space, and it's really inspiring for me personally to be part of that effort across the whole system. Many of the issues we face in Cheshire and Merseyside absolutely replicate what I've just talked about nationally. We're no different. But because we've got real pockets of poverty, we've got some particularly big challenges in some parts of our ICS as well, which we all know very well. So we're seeing many of the same issues in terms of child mortality, the front door. I thought this was a really interesting slide that colleagues have put together about the number of kids who are now who've now got an EHCP in Cheshire and Merseyside. Just look at the curve on that graph, the number of children increasing in that space. And this is really shocking, I think, is what's happening locally with speech and language therapy. So, and the wait times for speech and language therapy, can you see that we're now starting to see wait times of over 2 years for a child accessing speech and language therapy locally? How can that possibly happen? I mean, if a child can't speak at 3, then and they can't get any speech and language therapy, that's a pretty distressing situation, thinking about them starting school at 4 and 5. Our access to mental health services we've done pretty well actually compared to national figures, but even still, we're still struggling to keep up with demand, as we know. And we're seeing, certainly in terms of pockets of deprivation, very significant attendances for asthma across our patch. Unfortunately, we're struggling with obesity really significantly. We've got Q clinics set up in Alder Hay, which is tackling the very severe cases, but we haven't got, we're really just starting a really significant prevention programme, although that is now starting to get great traction through Beyond, which is fantastic. Just wanted to pick this one out as well. Not only are we seeing obesity go up, we're actually starting to see the number of kids who are underweight going up. And we think that is a product of poverty and food insecurity, which is extremely worrying. And I just wanted to end, if I may, Raj, by saying, you know, how wonderful it is to be part of a system that has come together in the way it has. The Health and Care Partnership have made children and young people a priority, and that we've got a governance arrangement now that has really brought the whole system together under the CYP committee And the work that's been done through colleagues across the system, in local authorities, in all of the places, through the voluntary sector, coming together to identify the key priorities for us. And also a shout out to the provider collaboratives as well, who've come together in a great way to think about children in a different way. So through CMAST and the Mental Health and Learning Disability Collaborative have now got streams of work also looking specifically at children, hospitals and providers coming together to think about children and think about new ways of providing services together. So that's my last point really, Raj, is a huge thank you to everybody in Cheshire Merseyside. I think we're probably an exemplar, if I may put it like that. There are a few places around the country who are doing this, who've taken the lead on it, but certainly Cheshire and Merseyside is one of them. And we're definitely now talking to ICBs across the country about the importance of doing this, taking this approach, taking a whole system approach, so that we can consider at local level what the key issues are facing our own populations and work collaboratively with colleagues nationally to come up with solutions for tackling them. So that's where I wanted to end, if that's okay, Raj, and I'm very happy, of course, to take any questions from colleagues.
Thank you, Louise. I guess I can speak on behalf of the board. A deeply upsetting picture that you've painted about the state of the health and well-being of children across the country, which is replicated for Cheshire and Merseyside. And as all of us know, we've prioritised children and established the committee, and we'll come on to that shortly. Right, Steve? Steve Broomhead.
Hi Louise, Steve Brody, hi.
Hello Steve, I'm sorry I can't see you, Steve.
Okay, no problem, better off. Thanks, first of all, thanks for your leadership on this, at both ICB and the national level, and there's no doubt it is a shocking tale of deterioration in the conditions young people face. Really pleased with what we're doing here in Cheshire and Merseyside. I'm a bit more worried about what happens at a more national level, because obviously Amanda from the NHS reports into the Department of Health, and the two of the main departments, the DFE, the Department of Local Government, DLUC, often aren't joined up about these issues really. So anything can be done at a national level, because it's national issues that basically impact a lot of the issues that you've described. Really good partnership between local government, public health and health at the local level, but it's the national scene that really worries me because of the silo mentality that tends to exist.
Thanks, Steve.
Yeah, thanks, Steve. I mean, just to say on that, Steve, I completely agree with you. I was quite shocked, actually. I mean, it's there, but when you see it firsthand, it is quite shocking. What I would say is that we've agreed as part of our work as a national board to really formally reach out now to the DFE and see if we can find a way of bringing, that work much more closely together. I think, truthfully, we need a bit of government leadership on it as well, which would be very helpful. We've met with the National Children's Commissioner, who is very committed to this, Rachel de Souza, and she's certainly doing everything she can behind the scenes to try and bring health and education much more closely together. But it's critical for children.
Thanks, Louise. Naomi, who's our GP Partner Director.
Hi, Louise. It was just a couple of comments, really. I think it does paint a fairly stark picture. Although Cheshire and Merseyside is doing well nationally, we are not. And I think just to highlight, actually the impact of the care that is provided by general practice for these patients. We are trained in cradle to grave care, but particularly when children and young people services don't have capacity to be seeing these patients, actually that falls back on general practice for us to be able to see those patients. So when we've got patients, as an example, in Liverpool, you're waiting for 2.5 years for an ASD assessment as a child. You're waiting for 4 years as an adult. Now, if you've got a 14-year-old who's referred and then is not seen within those 2 years, that person can potentially, so from 14 to 22.
Yeah, I know.
So it has a massive impact. So, particularly on education, on other mental health, so anxiety, depression, and again, this all seems to fall back on general practice. So it was just to kind of highlight that it's not just solely within children and young people services. This impacts on other sectors as well. And then I think the other comment that I wanted to make was, I know that, yes, obviously there is an issue with managing demands. I know we're talking about that later within general practice. However, I do also think that there's, you know, anecdotally, there's been a massive increase in the number of patients, the number of young people who are being seen who would previously have been self-managed at home. And actually, I think that as part of this project, I was really excited to see about the paediatric NHS 111, and what I'd hope to see kind of alongside of that is a real push for patient education on what is safe to be managed at home, and then for them to then realise that actually what that then means is that there is more capacity to see the patients who actually need to be seen, either at general practice or at you know, at A&E.
Thanks, Naomi. A lot in there, isn't it, Louise? And I'm going to suggest, just because of time, that's the last comment question from our board. Louise, is there any responses that you want to give to Naomi at this point in time?
Well, not to dwell on it, but you're absolutely on the money, Naomi, is what I'd say to you. You are speaking for the nation. Everybody is saying the same thing, and I know that locally completely from the Alder Hey point of view. We have got to wrap round together, haven't we, to come up with solutions outside of hospital that work for families. And that's, I didn't dwell on it, but that is absolutely one of the priorities nationally, and I know it is locally as well. So I think we've got some exciting times ahead, actually, working together to see if we can come up with solutions that really support families in a different way. Completely agree.
Thanks, Louise. Louise, just a word of thanks on behalf of the board. Firstly, thank you for the national role that you're undertaking, on top of your already very busy role as the CEO of Alder Hey. It does really make a difference nationally, but also makes a difference to us over in Cheshire and Merseyside, because I know you like us best.
Well, thanks for your support, guys. I mean, you know, as I said, I meant what I said at the beginning. It's so because of the richness of what we've done locally that I've been able to, you know, I think bring some of that, if I may, to the national people as well.
Thanks, and hope you recover soon.
Thank you.
Thanks.
Thank you.
Bye-bye.
Thanks a lot. Thanks now. Bye-bye.
Sobering, hey. Okay, should we move on to the Children and Young People's Committee? It's here for your approval. I think we've rehearsed the arguments before at this meeting. Adam?
Just quickly, one thought that's only just come about during that presentation, which was really quite moving. We spoke about, or Louise spoke about, children accessing A&E because they either didn't know to go to general practice or to other parts of primary care. And it does reflect on me that the committee membership doesn't have anyone from a primary care background on it by rote. And I wonder if we've just missed a trick there in terms of if we can educate both children and parents around how do they access care and what's the right place at the right time, will that determine future generations of using the right activities?
Thanks, Adam. I've noted that point. I chair this committee, so I'll explore that with committee members. Ruth?
My comment was similar lines, but a different sector. I was very struck by Louise's comments about DFE. And whilst you've got local authority, chief executive, I think, listed, increasingly the school sector is independent. And I just wonder whether you need the voice of education directly from schools or college providers to inform your work, whether it's as membership of the committee or to ensure that you have input. But I do think education is such a major part of a young person's life, a child and young person. I can just say what Louise has just described is where we need to be in tackling health inequalities, giving children the best start in life. There's so much in there that we can really make a difference with. So thank you for the presentation.
So on the voice of education, we've been attempting to do that through the Directors of Children. Is that the right title? Directors of Children's Services? So I'll explore that with them. Okay, thank you. Okay, so I'll continue with Ian.
It was just to assure the Directors of Children's Services on there, but we are exploring through them a rep for the healthcare partnership from education as well. So perhaps we can follow up with regards to the committee as well if we get the right rep for education on there.
Thanks, Ian. Okay, could I take, with those further clarifications and ensuring that we've got appropriate membership, people approve this and happy to take, give me the delegated authority to approve them once we made those changes. Yes, thank you. If we go on to Claire, primary access?
Yes,
Primary
thank
care
you.
access?
I've got some colleagues coming to join, so I'm afraid we do want a little bit of time, Raj, if that's okay, because it's quite a big agenda item.
It
so
is.
If I introduce it, and then, so I'm pleased to introduce this plan. We'll hand over to Chris and Jonathan, Naomi. I'm sure Adam will want to comment as well, and I'm afraid, and there are two place directors here, Mark and Simon, who may want to come in and explain how things have developed in place and how things are working. You remember that I brought an update or a high-level summary of the national document that was published on the 9th of May, the delivery plan for recovery access to primary care. I think it's called Recovering Access. It could be called Managing Demand, depending on which lens you read it from. So I think that's just something we want to have a look at. So the plan we're presenting today is the aggregate ICB response, but it's built up from the 9 places. I think we really need to emphasise it is primarily a GP access recovery plan. There's a tiny bit about community pharmacy, nothing around dentistry, which we know is a high priority for the organisation. But it does recognise the unprecedented demand for general practice services, but also how hard GPs and their staff are working. It sets out 4 key ambitions for the service, which look to transform and how care is delivered. So the ambitions are empowering patients, implementing modern general practice, access, building capacity and busting bureaucracy. Chris will talk through all of that in a minute. National funding has been invested in the delivery of this plan, and that's set out in Table 1 on page 10. It has been protected in the recent communications from NHS England, so we really need to make it work hard for the practices, but more importantly for the patients. We've worked with our local medical committees and health watches throughout the development of this plan, and we've sought assurances from each place that their place response has been developed in partnership with both LMCs and health watches. I think we've made considerable progress since the plan was published nationally in May, but there's lots more to do. And we need our practices to grasp the opportunities. But we know during COVID how responsive, flexible and agile our practices were to transforming services. So I know they can meet the challenges because they are the backbone of our healthcare system. It also makes asks of our residents to at times access care in a different way and develop a different relationship with our GPs and the wide range of services they provide. So I think with that introduction, it's okay. I'll hand over to Chris, who's going to sort of give us a bit of a detail of the plan, and then Jonathan and Naomi in particular are going to come in. Thank you.
Okay, I'll just introduce myself. Chris Lees, I'm Associate Director of Primary Care, the ICB. So, as Claire mentioned, in May, the government released a national policy document which was called Recovering Access to Primary Care. It was primarily aimed at general practice, but it has some community pharmacy elements to it. The ask of the ICB was that we must produce an access improvement plan, which should come to the board in either October or November of this year. The plan should be accompanied by an equality and health inequalities analysis, which is contained within your papers. And the plan should cover 4 elements. So the first element is around empowering patients, which is supporting patients for self-care and elements of community pharmacy. The second element was building modern general practice access, which Jonathan and Naomi will talk about shortly, which is around building a general practice that's modernised in terms of online access and taking advantage of all digital offers available. The third element is building capacity, which is around workforce, well-being and estates. And the final element, which Jonathan again will talk about shortly, is reducing bureaucracy. The ask was that the plan should contain clear metrics and should follow guidelines which the national team sent to us. And it needs to return to you as a board in either February or March next year and should be an ongoing piece of work. As Claire also mentioned, our approach was based on triangulating 9 place improvement plans, which in turn were based on improvement plans submitted by all our PCNs as part of a national contract ask, and all of our PCNs did so. So built up very much from practice to PCN to place into system. Now you'll see in the plan that there is a clear set of metrics and some of the headlines in there. You'll see that we have done some work in terms of increasing our overall appointments, good progress on realising and accessing NHS app functionality, and a lot of work done in a short space of time while people in John's team around digital telephony. You see that there's been an increase in direct patient care staff through taking advantage of the additional role scheme. And for the first time, we have everything that we do in terms of access under one umbrella, which I think was a useful exercise anyway. However, as Claire mentioned, you'll see there's still some way to go. Jonathan will talk about some of the challenges we've had in terms of reducing bureaucracy. The self-referral and the self-directed pathway work the deadline's been extended nationally in recognition of some of the challenges that ICBs are experiencing. And we have some challenges still in terms of GP numbers. We have more direct patient care staff, but our GP numbers aren't as high as the national expectations. And also, we're currently working through our response to the NHS long-term workforce plan, which came out recently, and that includes, of course, primary care. The other main gap, which I'm sure Louise and others from Healthwatch will say, is that we need to understand, is this making a difference on the ground, and how do we measure that? So you can have as many metrics as you like, but we need to do further work on, is it feeling different, and is it feeling better, which you'll see is contained within your next steps. So I'm just going to hand over now to Jonathan and Naomi, who are going to bring this to life a bit more in terms of actual practicalities on the ground. John?
Thank you. So, Jonathan Griffiths, I've been here before. I'm a GP. I'm Associate Medical Director for Primary Care for NHS Cheshire and Merseyside. I wanted in particular to draw your attention to the cutting bureaucracy section, because that's the one section in the plan that we were asked to come specifically to board to present in the autumn. We're not bringing a separate paper, but it is part of this overall paper today. And the reason I think this is important is that of all the aspects within the plan, most are for primary care to deliver. This section is pretty much entirely for secondary care to deliver. It can only be done by a full system approach rather than GPs doing something different to deliver it. And there are 4 asks within the cutting bureaucracy about checking about onward referrals, so consultant to consultant referrals, complete care, hospitals providing fit notes and discharge summaries, call and recall systems within hospitals to ensure that patients are not asked to go to their GP for follow-up of investigations that have been initiated in hospital, and then having single points of contact for both primary and secondary care to communicate with each other. We've done a lot of work on this. It's detailed in section 7 of the pack. We have our consensus document on the primary secondary care interface, and we really are leading lights in the country in terms of that document that has been produced. So we are looked upon from others around the country to say, well, how did you do that? And what difference is it making? So we should be very proud that we have that to build our other conversations upon. We have primary secondary care interface groups across the geography now working on the ground to make changes that will improve pathways for patients. We're developing a comms toolkit for trusts and places to use, and a trust and place checklist as well. And I'm hoping to try and get those up and running in the next month or so out to trusts and to places. So that's the cutting bureaucracy section, which I think is really important. The other bit that relies on a system approach rather than general practice are the self-referral section, which is earlier on, where we're working with community service colleagues to ensure that patients can directly refer themselves for things like musculoskeletal services, audiology and hearing aids, wheelchairs, weight assessments, podiatry. That requires our community services colleagues to be changing their pathways. I believe we're looking at a timeline for about March for that as well. I'll pause there and see if Naomi has anything she wants to add to this, and we can answer any questions that people may have.
So I think it leads on nicely from what Jonathan was saying. I think actually each one of these sections is not about general practice in isolation. I think each one of these sections needs to be taken in collaboration with other partners. So particularly with empowering patients, you know, we need to have that engagement with patients and, you know, through the likes of Healthwatch to see actually what is it that patients are wanting and what is it that they need. And also then to be able to educate patients with actually the realistic like aims and achievements of this plan. Yes, there is potential in this plan to increase the number of appointments, but that still may not meet demand. And actually what we need to do is to be able to then educate patients in seeing the right person in the right place at the right time. So particularly with the modern general practice, you know, yes, this is to tackle the 8 o'clock rush, but actually what that I spoke at the AGM regarding regarding the digital telephony, and explain that actually knowing that you're number 102 in the queue doesn't help when there's only 80 appointments available for that day. However, what it does do is give the general practice data to look at when is the demand highest, and therefore be able to change the system or change the rota to have more people to be able to meet that demand on that day. Building capacity, again, this is it's not just about seeing a GP, but being able to increase additional roles. So we've got the R's roles that are being embedded via the PCNs, but also again with that, there's the patient education that is currently being done nationally, so that patients can understand, and then they can therefore request, do they need to see a GP, or could they go and see a physiotherapist? Is this more of a social problem to see a social prescriber, or do they need a dietitian, for example? And then again, the cut in bureaucracy, it needs to be done in collaboration with secondary care. It would have a massive impact and free up multiple, so much capacity, not just within general practice, but also within secondary care as well, because you wouldn't constantly have the back and forth. If there was if there's a kind of a set protocol or a set communication channel between both primary and secondary care, and also primary care and patient and secondary care and patient, actually that should free up capacity within both primary and secondary care. Particularly with the pharmacy team, again, this is about general practice and pharmacy working together. When the pharmacy team are able to are funded to see patients and to manage patients, actually that also frees up appointments within general practice. So I think although we do need to I think we need to be aware that this isn't a fix-all, but actually I do think that it will have a massive impact on improving capacity within general practice.
Adam?
Thank you, everyone. I think this is really timely, and it mentions in the paper around the new news we've had in pharmacy about the Pharmacy First. And what Naomi said is bang on in terms of we're going to have 7 common conditions. They're going to be able to be treated back to front in pharmacy. So that's uncomplicated urinary tract infections, sore throat, acute otitis media, infected insect bites, impetigo, shingles and sinusitis. Normally they would have mostly been a referral into general practice. It no longer needs to be the case. We are going to need to really major on comms about this, both to the public but also within health systems, because there's some parts of the new service that consume the old consultation service that required a referral, whether that be from NHS 111, from general practice, from urgent care, or whatever part of the system. And we need to make sure those referrals still occur to drive the service. There's a couple of other bits I wanted to pull out. The negotiation that's just been concluded does also include the ability for more staff other than pharmacists to deliver the hypertension case finding service, measuring blood pressure and finding the undiagnosed. And I think we heard about the issues with blood pressure earlier on the performance report. We probably need to give a little bit of thought about how we deal as a system if we get an influx of more patients undiagnosed previously into the system. Because certainly if that area is driven hard, that will be something for us to tackle with that might put some pressure on. The other thing around the building capacity element of it, I was really pleased to see the pharmacy graduates appear on there in the building capacity section of the paper. But with the move towards independent prescriber status, the move towards service delivery, I think there's other parts of the pharmacy team that are really key, particularly pharmacy technicians whose role is being expanded. So we know they're going to be operating the hypertension service. There's a consultation out there with government about them operating patient group directions at the moment. So I think we probably need to put some thought onto how to drive those numbers up as well as just the pharmacists. So I think pharmacy technicians possibly need adding into that line as well.
Thanks, Adam. So, really comprehensive paper. There's a lot in it. Highlights and the further analysis and point of priority that have been articulated, hugely important to us. I'm going to see some comments, questions on the board. Ruth, but before I do, I'm going to ask Tony just to chair for 60 seconds as I go outside.
Claire suggested it might be a good idea to give a place perspective on this. Or did you want to go first, Ruth? Sorry. So Wirral performs quite well in terms of the GP patient survey. We're in a good position in terms of the numbers of doctors per head of population, but that's something to build from, I think, for us. And we saw this as an opportunity to do have sort of once and well approach across Cheshire and Merseyside, but then really clear place implementation that connects to our wider system. We mentioned Health Watch. I think Health Watch for us has been key in design, in implementation and assurance around this. So they've helped work with the 5 PCNs, our PCN Collaborative, our Primary Care Council, our local representative committees. So it's not just LMC, it's the local dental committee, Optum committee and pharmacy committee about getting this right for how we work collectively. So there is things about care navigation training across all 5 PCNs. There's the improvement programme, there's cloud-based telephony, but when we look at how we deploy the Service Development Fund monies, how do we help the urgent care system through this winter? So our GPs have come back with a proposal around something that takes us beyond an acute respiratory hub as part of this. So we also have development of things like women's health hubs and also the enhanced access, which again is being reviewed by Health Watch. So we have some clear metrics, figures, investments in this, the increase of the R's roles, again, partnership in terms of working with the mental health provider and the mental health roles. And we see this increase as an opportunity to support primary care in its widest sense as part of our health and care economy and recognise the mutual dependencies that exist within our system around that. So thanks to Jonathan and Chris and Claire for pulling this together, leadership on this, and particularly Jonathan's leadership about the secondary primary care interface work.
Thanks, Simon. Ruth, please.
Thank you. Well, first of all, well done. It's so pleasing to see such a comprehensive piece of work on primary care. I recognise it's mainly general practice, but it needs attention, and this is a great basis to go forward, and lots of issues described here, so well done. I look forward to seeing how it progresses. And equally pleased to see the equity impact assessment. It's extremely comprehensive. My question is, when developing the dashboard, that we think about how we can integrate EDI considerations into the dashboard. The danger, and I think it talks about doing the continuing inequality analysis with more bespoke plan. And the danger is we have an EDI approach here and then the sort of general approach here. And there's a real opportunity, I think, through the work you've done so far to try and think about how you actually make a core to what you do. So in developing the dashboard from January onwards, have a think about whether there are things that could be actually integrated at that point.
Thank you. Is it Graham next?
I think it's Louise.
Louise and then Graham.
Thank you. So a couple of things for me. We have been very much listened to as Health Watch by the people that have put this together, and I think that's all credit, because talking to colleagues from elsewhere, not in Cheshire and Merseyside, I'm not sure that's been the case. So people have taken on board the comments that our public have made, that we've heard, and that we've then fed in. So I think that's first of all really important. I think there's a couple of things, there's going to be a but, isn't there? There's a couple of things in there, though, that it's interesting. So Simon's just outlined work that colleagues on Wirral have done, which we are aware of, which is great. But your Health Watches all work differently. So that won't have happened across each of the 9 places. And I do think there's something within this as to how we're looking to make sure that you've got consistent work going on. And that's a challenge for us as well as back to the board. And I think within that somewhere is the next steps. Of course, I'm going to say that. You preempted me, which is just as you would, Chris. And I think it's really a common ownership as to how we're understanding. So yes, we can put in what we'd expect, what people have told us, and so we'd expect to see. But it's what's going to be sufficient for this board to seek assurance from our public that this is making a difference for them in their daily lives. So I'd welcome that conversation coming towards me, I'm sure, very soon.
Thanks, Louise. I've got Graham and then Steve.
I just wanted to contextualise this and to say I accept that there is no such thing as the average general practice. I also accept that some of the R's money is the continuation of a previous scheme, but just to set this in context, this is about £270,000 per GP practice. Now, the money hasn't been dished out like that. Some of it's been targeted per need, some of it's been distributed in different ways. But this is a significant investment in stabilising and improving our general practice.
Thanks, Graham. Steve?
Well, first of all, thanks for a really good piece of work, actually, and to welcome upon. This is a perennial issue that comes up in the 9 places in terms of access to the GP and is reflected quite often in deteriorating NHS patient surveys. When you get to see the GP, the satisfaction levels are actually very high. So I think you're addressing what is a major issue. Really good you've addressed and engaged with Health Watch, as Louise said, but I do think it'd be good to have a summary of this plan for health and wellbeing boards, because this matter comes up at most of the health and wellbeing boards in the 9 places, and also comes at the council's health scrutiny panels from time to time as well. Thanks.
Thank you.
Thank you. If I just can just sort of answer that directly. Yep. So thanks, Steve. As I said at the beginning, this is the aggregate. So each place has its own version of this. So very happy to do an exec summary of the aggregate Cheshire and Merseyside plan. But I think probably better for local health and wellbeing boards to receive the place version of it, or we can do a bit of both, and because you know, I'm sure Simon has spoken at place partnership boards and health and wellbeing boards, and you know, each of the place directors, but I think that's probably the plan you really want to get into the detail of, and then we can just do sort of an exec summary, or we can use some of our communications material, which will give you the summary document. So thank you.
Thanks, Claire. Steve, any other questions or comments? Tony?
Yeah, we could just pick up on the investing in our primary workforce section there. I think, and picking up on Graham's point there about the additional roles reimbursement scheme being a legacy that we've inherited, and what I think we've inherited is a very varied use of that optional funding in practices. But again, Adam's point there about pharmacy, I think there's a chance here that we could look at from the patient point of view. When you think you have a need, you live in a particular locality, your GP practice is the key connection, but it shouldn't be the only one. It should include pharmacy, and I don't think, certainly my personal experience is, there's enough offer to patients of there are additional supports you could get here from this practice. The 8 o'clock rush is still trying to get to see your GP. That's unhelpful, and in many cases it clogs the system up, but I think we've not gone far enough in promoting this whole idea that there's a thing called primary care or first access to your care needs, which includes pharmacists and a range of other roles. My concern is that the last time I saw the data, there was a very varied presentation of additional roles per primary care network, and I think it's something that we ought to work towards standardising that. It would make a big difference.
Thanks, Tony. Claire?
So where you said in a previous item the Chief Executive Chair might disagree, I might disagree with my colleague next to me in terms of standardisation of roles. There is a list of additional roles through the R's scheme, and if I'm honest, my preference would be for the practices and PCNs to identify the staff that they need, best meet the needs of their population. So that's why we have such a varied sort of choice of additional roles and workforce across Cheshire and Merseyside. Practices identify what they need. You know, the investment is based on need. So, you know, the choice of and the recruitment of staff is based on the needs of the populations. I think we have had problems in some cases, in some places, and some PCNs to use the full amount of that R's monies. There are many different reasons, and I'm sure Naomi and probably Fiona from a general practice perspective can outline those, and Jonathan. But I think it's important that, you know, this is bottom up, so we let our PCNs and places determine the right workforce for their population. And just another point, just in terms of communications, we've got there's a communications plan attached to this in one of the appendices. And unfortunately today we wanted to have on the screens, there's a campaign that the national campaign around ours and additional roles, which is all over the our website at the moment. And it's really helpful because it sort of outlines what these additional roles can do for the population, so it's not the automatic ask to go and see a GP. So there's lots of information there, so thank you.
Yes, and we'll probably continue to disagree, but I don't disagree
We always
entirely.
do.
That I think there ought to be some minimum requirements rather than standardise the whole thing, because I think there's emerging some gaps in some PCNs in the availability of some of these key additional roles that I think would solve a lot of the problems.
Some of that is workforce availability as opposed to... So, I mean, there are lots of reasons. And I mean, the System Primary Care Committee is the committee where we discuss this in detail, and we can seek some of that assurance through that.
But I guess what it's looking through the eyes of the residents and the patients. That's how we need to look at this. I think that's where we should be. Naomi?
Yeah, I do take Tony's point in that there is massive inconsistency between PCNs, but I think also we need to allow the flexibility for PCNs to be able to provide a localised service for what patients need. There are already restrictions within the R's roles and within PCNs of how many particular roles you can employ per capita. And I think if you increase the number of restrictions, actually that could have a negative effect. I think I do need to mention that particularly for some areas, estates has a massive impact on how many additional roles you can employ. If you don't have anywhere to put a physio, they're not going to be able to see you at the end of the day. I also think, so again, I feel like I'm a dog with a bone today, but it's patient education and patient engagement to explain, I think there is sometimes the perception that if you are offered something other than a GP, you are being fobbed off. And actually it's being able for patients to have that understanding that actually the GP is not necessarily the best person to see you regarding this issue. Part of that is included in this plan. So with care navigation, there's been funding available for practices to train their reception staff to become care navigators, so that every single contact, so every single telephone call, e-consult, when that comes through, that those care navigators are able to offer a range of services to those patients. It doesn't necessarily have to be the GP. And I think that will also then have an impact on, going forwards. Patients will know that they're able to request a physio or, an alternative role.
Thanks, Naomi. I'm going to draw this item to a close. We've been at it about 25 minutes, I think, now. If I could just pull two key things out that I've heard. Lots and lots of really important priorities, issues, and good progress being made. But this question about how do we support and the population to understand what these opportunities are providing, hugely important. We've got a comms plan, but we'll always put that to a test. I know this is not just the only action, but a website doesn't do it, does it? We know that. And the other one is it's a system approach, and it is not just lying on the doors of our GP or primary care colleagues. It's understanding how we connect the dots with secondary care and so on and so forth. Jonathan, Chris, thank you for presenting in such a precise way. That was really, really useful for me from a time perspective. There's a lot more to hear on this, and I'm sure we'll hear that both through the primary care committee and at appropriate junctures in as a board agenda item. Thank you very much. If we could move on, Claire, to the forward plan.
Yes, and I don't know how you want to do this, Raj, in terms of time, because the planning guidance hasn't come out yet. Planning guidance is usually as Christmas Eve is sort of the NHS joke. But you'll know that the current plan, the interim healthcare partnership strategy and the 23-28 ICB joint forward plan was developed at pace and in line with the planning guidance. And I think what we want to do through this paper, there is a slide deck, which I'm just conscious of time and whether anybody can see that, including myself. What we're proposing to do is make much greater alignment between what we as an ICB does and what the Healthcare Partnership does. So what we're proposing through a series of steps, primarily through the Joint Forward Plan, looking to comprise of a refreshed, altogether fairer, which we will be recommending at a future meeting, we adapt and adopt as the HCP strategy, as well as the 9 delivery plans and our NHS ICB delivery plan. There's a lot in the report, it's quite detailed, but I think in terms of time, it's just really about how we move this forward as a board. So what I want to propose is, there's lots of information here and we can circulate the slides. That one's quite an important slide in terms of how the drivers behind the Joint Forward Plan. So in terms of that strategic approach, that system approach with Altogether Fair and our local authorities building up from the Health and Wellbeing Boards, but also our supporting strategies. Claire's going to talk about later the finance strategy. You've just really seen the primary care strategy. Rowan and Fiona have talked about the sort of developing clinical strategy. So there's a whole raft of supporting strategies which will support our planning as we go forward. Then obviously sort of the national guidance around the NHS, which we have to adopt. So this paper talks through all of that. And I think the key thing is what's the role of the board and how does the board engage in the development of the planning process for 24-25, but also the Joint Forward Plan, which is a 5-year development. So I'd welcome comments from board in terms of how you'd like to be engaged in that. I'm proposing we bring something back in January when we've had the planning guidance and we've done further engagement. We have already started that engagement with some of the places. Colleagues met with the Directors of Adult Social Care yesterday and they welcomed the approach for a more system, wider determinant approach to our planning and our work. But really how Raj, yourself, the non-execs, the member partners want to be engaged in the development, either through some reference groups, some buddying or anything like that. So because of the time, if I leave it there, but happy to take questions from boards, but I'll bring something back in January.
Just let me make some supplementary comments. I think we as a board need to be really clear on understanding how we're identifying the priorities that we'll be working on across this period, in addition to the mandated ones. So there's a process there, isn't there? And then there's the how. Us as a board understanding from the executives what strategies, enablers are going to deliver those priorities. That feels like quite a significant session to me. I think we have in February we have a board development time out. Pretty sure it's in the middle of February. That feels like the right time to have some of that conversation, unless you're going to tell me it's too late.
Both, it might be a little bit too late, and also there are other items identified for that session, but there's probably something we'd quite like to do separate with board, probably offline, so to speak, around the development of this. But I think wait till the planning guidance has arrived around about Christmas time and look to set something up in January. Which might
One of the most
suit
difficult
you
things,
and-
Claire, is just getting things in people's diaries.
Yeah, no,
So
I appreciate
think,
that.
Given that's too late, let's try and identify a time in January where we can get a half a day for the board to be informed, as well as discuss priorities and the how.
Yeah, thank you.
Are people comfortable with that? And we will do stuff offline to support,
Yeah, that's
really
great,
productive,
thank you. Thank you.
productive session.
I support that. I think what would be helpful as well would be an update on the current year's plan to see where we are with that and what's successful and what lessons learned from that as well.
Yeah.
Thanks.
So I think in the appendix, one of the appendix, Neil, you can see where the priorities for this current year's plan, where it's reported through which committee.
Yeah,
So
I'd just fetch it all together. I know it goes through all the assurance committees, but just fetch it together as a composite document would be good. Okay.
Thank you. Useful. Okay.
Thank you.
Thanks, Claire. Can we move back to the winter plan? A lot of conversation and discussion on this already, Anthony and colleagues. Anthony, is there anything else that you wanted to say? Because otherwise I'm going to bring in the two place directors first to make some comments on place level plans.
I think, yeah, we've had the discussion earlier about this. I guess what everyone is acutely aware of, as Anne brought the reality of the current situation to life, just in terms of our own hospital, is that now's not the time to start coming up with cunning new ideas and additions to the plan. It's December tomorrow, and the pressures are already here. So the message that we've been consistently giving in recent weeks is one of deliver the plan that is already there. Don't start thinking of plan B or C or D. And we've tried to hone it down to 3 core elements, really. Of course, there's a lot more going on, and you can see that in the paper, but predominantly we are looking at, with the focus primarily, I guess, on the 2 key metrics of how winter is measured, the safer winter, the better winter, the phrase that we keep hearing. The way that that will be deemed nationally is how the 4-hour performance standard is delivered as a barometer of overall flow, and the highest risk in the community, that of the unknown or unknown patient, that patient waiting for an ambulance. So it's the CAT2 mean response. So we've took that down to 3 elements, really. And one of them is clearly the element that we discussed before, the number of patients that exist within the acute setting, the non-criteria to reside. And we've placed the place director at the centre of the coordination and the convening of those efforts. And as you say, there's 2 here that may wish to comment on that. Secondly, we've been pressurising or understanding with our acute providers how they are delivering the level of G&A beds that are open. We can take comfort that the overall winter plans will demonstrate more G&A beds in Cheshire and Mersey than we had at the peak last year. But that plan, as we sit here now, there are 113 fewer beds open today than the plan would suggest. So we're having those discussions trust by trust. And finally, the approach we're taking with our ambulance colleagues is that they are commissioned to provide a certain number of hours and a certain number of vehicles each and every day on the roads of Cheshire and Mersey. And they are about 7 or 8 vehicles short of that as we sit here today, with a plan that will be fixed during December. So they're the 3 elements that we're holding as our daily battle rhythm. In terms of oversight of that, we have the Strategic Coordination Centre in place from next Wednesday. It becomes what's defined as a smarter Strategic Coordination Centre, in that we will then have visibility every 2 hours of the current pressures that exist across the system, predominantly within the acute, but also within community and mental health and primary care. So I'll leave it there, Raj. As you say, you may bring other people in at that point.
Thanks. Simon, Mark, could you just give us some headlines?
So headlines, I suppose, is that unscheduled care, and thus the winter plan, has been key, the key sentinel programme, and we're all for a good 12, 18 months now in terms of the focus of the place board. Our SRO for this is Janelle Holmes, as the Chief Exec of Wirral Hospitals. I think our key components are about getting people out of hospital quickly, both in terms of people who are on pathway 0, pathway 1, so maximising use of virtual ward, but also home first. Making sure that when people are in hospital settings, the processes to get them to discharge are fluid, but also we make sure we look at things like hydration, nutrition, mobilisation, to make sure they're in a good state to get there. And then when there is a need for discharge, the establishment of a transfer of care hub and some care arranging teams, and to make sure our capacity around intermediate care beds, reablement, which Hilary mentioned earlier, is where it needs to be. And in doing that, there are some areas we need to build on into next year's financial planning, for particularly for people, elderly mental health, who are not necessarily amenable to rehabilitation, but we need some sort of focus for them. I think also in the winter plan it does reflect our need to focus on mental health provision as well. So with the support of the strategic, the system coordination group and mental health providers and colleagues in places, we have started to roll out the adult mental health escalation framework, which enables people to flag where we have excessive waits in EDs, and we would then expect a place to take some action around that. And then when we can actually have more regular multi-agency events to actually move some of those people in a long stay setting in our mental health inpatient beds. Demand in mental health has gone up in a similar way to that for mainstream physical health services, and people presenting not known to services has gone from 8% in 2019 to 27% now. So we're seeing that increase. So therefore, that's about also investing in admission avoidance and crisis services in our mental health services as well. So that's a run through the things we're looking at, and we're all playing into that more global solution, particularly around the mental health escalation work.
Thanks, Alan. That really brings it home. Mark?
Yeah, cheers, thank you. Thanks, Raj. I won't repeat what Simon said, but just to build on that a little bit more, if I may. I guess the first thing to say is we've got a Cheshire and Merseyside plan presented here today, but it's absolutely been built from the bottom up and from the plans of the 9 places. So I just wanted to say that that's been the process. We've engaged locally with public, we've worked with our local Health Watch, we've worked with our PCNs and care communities, and we've actually started to stress test the plan, which I've not always seen with kind of winter plans in the past. So I think that's been a welcome development. We've got a particular issue in Cheshire East, and I want to go back to the no criteria to reside debate we had a little bit earlier on. We've got fewer beds in Cheshire East across Mid and East Cheshire. In Mid, the discovery of the further deterioration of the concrete structure at the beginning of the year meant that Mid Cheshire had to decant 2 wards at very short notice. That's relevant when we look at no criteria to reside percentages, just to link it back to the percentage point, because we need to look at the bed base, which has been lower for RAC-related reasons at Mid, and at East Cheshire we've also lost beds because of the ward that's gone to support the return of maternity services. So those are very, very positive things, but they've placed our hospital bed complement under some pressure. Really pleased that's been recognised by central colleagues with some additional investment into Mid Cheshire that we may touch on later on as part of the financial discussions. Two final points to make. I think primary care remains fragile, and we need to remember that a very small change in primary care capacity could have a disproportionate impact on our hospital-based services and other services across the system. GPs locally, and I'm sure across C&M, are disappointed at the lack of additional income in additional capacity across the winter period. So that's certainly affecting GP mood locally. And the only other point I want to make is that we're seeing some initial signs of delays in social work assessments for continuing healthcare, which we think may reflect some of the pressures that our council colleagues are under as well. So there's a range of factors, probably under the kind of broad heading of the system, that we do need to keep an eye on as we move into the winter period. But absolutely support the winter plan as presented here today. Thank you.
Thanks, Mark. Hilary?
Yeah, huge amount of work, and thanks for presenting that. The challenge, I think it's been reflected, is keeping the bed base open, hence the ICP, infection prevention control debate we had earlier. A couple of questions. Locally, do you have the intelligence in relation to how many care home beds are available at any one time at place level? I suppose that's my first question. My second question is, the alignment, I suppose independent care providers like domiciliary care providers, for example, would have their own winter plans, wouldn't they? And are we cognizant of that at a local level as well? Do we understand their winter plans? Do they understand ours? Is there any sort of mutual aid we need to give to each other?
So I can perhaps comment on that. I'm sure Simon can build on that from a Wirral point of view. We absolutely know our care home bed capacity, I think on at least a weekly basis, but perhaps more frequently. So we've got a reasonable grip on that. We know waiting times for domiciliary care at any moment. And just to link back to the no criteria to reside debate earlier on, and I think Neil was talking about, how granular can we be? We've got real-time information on why people are medically optimised but are still in hospital. There are a set of reasons for that, but we've got that information on a real-time basis. So I think we're well placed in terms of having the data. It's obviously what we do with that and how amenable all those problems are to a solution. But I certainly think we know what the issues are. Would be my sense of it.
Thank you. Quickly, Simon?
And I also think we need to approach it from a no bed like your own bed approach, because actually we don't want people ending up in an acute trust bed. We don't want people ending up in a residential home bed. We actually want to keep them in their own homes for as long as is possible. So that's the importance of home first, it's the importance of mission avoidance, it's the importance of virtual world, which you started the meeting with. So they're the key things that are driving our thinking around this as well.
Completely agree.
Thank you. I'm going to move us on with this final comment, which is I look forward to the time when the winter plan is truly a winter plan about seasonality rather than the fundamentals of our capacity and demand that we have in our system across all our partnerships. And as we've articulated, the winter pressures, as so-called, is our number one priority, and that's we will hear over meeting after meeting about how we're trying to make progress on resolving some of those key issues. If there's no other comments, I'm going to close the meeting now. It's been a really productive, challenging meeting, which is great. So thank you very much for that. But before I let you go for lunch, I'm going to ask the board if we could stay behind for another 15 minutes or so, because what we were intending to do at the beginning of the board was to have half an hour with our with our members of the public, some of whom have travelled a long way to come here, to give them an opportunity to ask us some questions. If I could say to the member, Bob, could we move that down to 20 minutes to give us time to get to our next meeting, if that's okay? Just want to say this in terms of introduction. This is new for us to have this dedicated time, and it will always be here at our public meeting.